Hi, good morning everyone. It's always wonderful to back in Kerala because I worked here for almost 3 years and it's always like a second homecoming. So I would like to thank Francis sir and the entire team to give me this wonderful opportunity to open the innings with lessons in molecular risk adapted adjuvant therapy in endometrial cancer. So if you see this dualist Bockham classification which came in 1983, it was the basic classification where endometrial cancer was divided into two types, that was endometrioid and non-endometrioid variety. And if you see the endometrioid, they were mostly low grade, it is 85% were mostly type 1, they were mainly estrogen dependent tumors, and if you see the type 2, they were mostly of high grade estrogen independent and they were only 15%. If you see the FIGO 2023 staging system in endometrial cancer, it came almost after 14 years because the last it was on 2009, and in between 14 years have been elapsed and so many things moved. And there was a drastic impact on treatment of FIGO 2023 staging system. If you see the traditional staging system, which means it is a statement of the anatomical extent of the disease at the time of presentation, it is determined by clinical, pathological and radiological information. But what this staging system done, what they have done, they have incorporated LVSI, they have incorporated type of histology, they also incorporated molecular system into the staging system. So rather than become a simple staging, it has become a risk stratification actually. If you see this FIGO 2023 staging system, mainly three changes. I will come one by one. So it is about the histology, again LVSI, molecular pattern, and also pelvic peritoneum versus non-pelvic peritoneum, nodes divided, again C1 and C2 into 1 and 2. So there are a lot of changes. So in between 2013, this landmark paper came in Nature, which was Cancer Genomic Atlas study, where they have divided endometrial cancer into 4 types. One was pole ultramutated, extremely good prognosis, P53 abnormal endometrial cancer, extremely poor prognosis, and in between there was MMR deficient and non-specific molecular pattern. These are the 4 types of endometrial cancer what they have mentioned. If you see the workflow of diagnosing and molecular typing of endometrial cancer, you will find that first in the pre-op endometrial biopsy you should go for a pole status. If it is pathogenic, fine, pole mutant. If it is pole is wild type, check MMR, whether MMR is deficient or proficient. You have ruled out MMR deficiency, then you come for P53 status, whether P53 is abnormal or wild type. This classification came ESGO-ISTRO ESP endometrial cancer guidelines 2020-21, and you see in that they have divided into two types. One was molecular classification known and there was molecular classification unknown. So molecular classification has been incorporated before only 2020-21. It is not new. And if you see the changes in FIGO 2023 staging system, 1A is divided into 1A, 1A2 and A3. Especially if you see 1A3, it has to meet all the 4 criteria, then you can say that whether endometrial cancer involving endometrium and synchronous ovarian involvement, what are the 4 characteristics? Low-grade endometrioid type, absent or superficial myoinvasion, absent or focal LVSI, absence of additional metastasis, and it should be unilateral and there should not be any capsular invasion or rupture. Then only you can say it is 1A3, otherwise it will go to 3A or it can be a separate ovarian primary. If you see 2, again they have divided 2A into cervical stromal involvement, 2B substantial LVSI, and 2C there is aggressive histological types with any myoinvasion, be it less than 50% or more than 50%. Significant changes in stage 2. Stage 3, mainly if you concentrate on the peritoneum, previously peritoneum involvement means it was stage 4, now it is 3B2 if there is pelvic peritoneal involvement. 3C1 pelvic lymph node metastasis divided into micro and macromets. Similarly para-aortic node involvement 3C2 that is divided into micromets and macromets 1 and 2. And 4B that is peritoneal metastasis beyond the pelvis, but they have not mentioned about peritoneal washing. If the peritoneal washing comes positive, nobody knows what is the stage actually. If you see the ESGO-ISTRO ESP guidelines prognostic risk group, you will find that low risk, there is chance of less than 8% recurrence, no adjuvant treatment is required. Intermediate risk, 8 to 15% chance of recurrence. you need adjuvant brachy at least. High intermediate risk, 15 to 25%, where you need adjuvant EBRT, and high risk, more than 25% chance of recurrence, you want to escalate your treatment. That is systemic chemotherapy plus radiation. Obviously now immunotherapy is coming into picture. If you see the NCCN guidelines 2026, still they are based on FIGO 2009 staging system. They are saying 1A grade 1, grade 2, you need not go for any adjuvant treatment. But if it is 1A grade 3 or 1B grade 2, then vaginal brachytherapy versus observation needs to be discussed. Stage 2, straightforward, it was EBRT plus vaginal brachytherapy boost. And then if it is stage 3, 4, then you need escalation of treatment, systemic chemotherapy plus minus radiation. But all these things changed. If you see this landmark publication which came in Lancet in 2025, ESGO ISTRO ESP guidelines update in 2025, what they have done, they have made it a bit complicated. Yes, POL ultramutant was there, P53 abnormal was there, NSMP was there, MMR deficient was there. What is new? They have divided NSMP into two categories, ER positive low grade and ER negative high grade. So NSMP divided into two, and according to that, I am fully colorblind, but what they have mentioned, I read it, they have divided into 4 or 5 types. Gray zone, nobody knows the answer. Here you can see the gray zone very well. There is green, that means they are of low risk, no adjuvant treatment may be required. If it is yellow, then it is intermediate risk, where you can go for vaginal brachytherapy, and if it is high intermediate risk, external beam radiotherapy has role, and if it is red, you need escalation of treatment along with systemic chemotherapy plus or minus radiation. So these are the 5 categories they have mentioned. If you see L1 CAM, L1 cell adhesion molecule, that was not, though it will come in the future definitely, especially in the NSMP group, you can divide into L1 CAM more than 10% expression versus less than 10%, and which can change the prognosis further, though it is not in the 2025 update in the Lancet paper. So I am giving one case example, 54-year-old lady with baseline MRI. It was done on 13 January 2023. You can see the signal intensity changes in the fundus. So what are the TMC histo? Finally surgery was done, and what you can see in the final histopathology report, it was serous carcinoma, high grade, P53 mutant, and it was an endometrium confined disease. There was no myoinvasion. So it was endometrium confined, serous carcinoma, P53 mutant. What to do next? It was P53 mutated, endometrial serous carcinoma, endometrial polyp only. Actually, nobody knows the answer. According to the latest update also, it comes in the gray zone. So it was dependent on physician's discretion. At that point of time, when after surgery, we gave VBT 7 grain to 3 fractions, completed in April 2023, and last follow-up in July 2025, patient is doing well. Because endometrial confined disease, P53 mutant, whether you have to add chemotherapy or not, we don't know. Once there is myoinvasion and P53 mutated, it becomes high risk. But if it is endometrium confined, we don't know the answer. Whether to give EBRT, we don't know. We don't have any robust evidence. We delivered VBT. I don't know whether it is wrong or right. Patient is doing well. And if you see, there are limited data suggesting that the risk of recurrence is somewhat higher than that of a low-risk carcinomas, but not as high as intermediate or high intermediate risk. And this comes in the gray zone, and we have given VBT. So what is the evidence? You ask me, where from you have got this? It was 2009. If you see, it was 1A, and 2023, it becomes 1C. And if you see this study, where you will find that serous carcinoma 74%, 74 patients were there. They have done lymph node dissection, VBT 7 into 3, chemotherapy 34% of patients, and if you see the 5-year OS, it was 84%, and chances of recurrence, pelvic recurrence less than 5% in 5 years, and extra pelvic recurrence around 10%. So this can be one of the old study which we followed. I will come to another case, 58-year-old lady presented with postmenopausal bleeding for 6 months, hysteroscopy and endometrial biopsy says high-grade carcinoma. Underwent total laparoscopic hysterectomy with bilateral salpingo-oophorectomy with bilateral pelvic node dissection, para-aortic node dissection plus omental biopsy. So nothing, everything you have done, no stone unturned. So what was the histopath specimen? It was endometrial clear cell carcinoma, tumor invades less than half of the myometrium. So it was non-endometrioid histology, less than half of the myometrium was involved. So according to the older classification, any myoinvasive high-grade non-endometrioid histology comes under the high-risk category. So, according to this if you can see the high risk, it was stage 1 to 4A non-endometrioid histology, and with myoinvasion, it comes under high risk. So, ideally patient requires chemotherapy and radiation. It can be sequential, it can be concurrent. Then we have done the pole testing in our lab, and it came as pole mutant. So now, less than 50% myoinvasion, clear cell carcinoma, pole mutant, what to do? If you see the current system, then you will find that this should come a bit lower down. It is a high grade histology, myoinvasive, and if it is pole mutant, it comes under the green one. So it is actually now low risk, and so our MDT decided that we will not give any adjuvant treatment. So thing we don't know, because if you see, all this system was based on older staging system, all data we have according to the older trials, but this decision we took, and in the future we will come to know whether really it was right or wrong, but there is emerging evidence where it shows that pole actually supersedes your morphology or type of histology, and that's why we took this call. So it comes now it became low risk. From high risk, it immediately shifted to low risk with the molecular classification. Now I'll come to another case, 39-year-old lady presented with CA endometrium, stage 2A, grade 2. Cervical stroma is involved by tumor. So all lymph nodes are free. What adjuvant treatment next? It was very easy for us. Cervical stroma involved, you go for a EBRT followed by VBT. External beam RT 45 grade 25 fraction 5 weeks, vaginal brachytherapy 5 or 2, 5 into 2 or 6 into 2, finish it off. P53 was not mutated, so you can avoid chemotherapy. Now it came as NSMP ER diffusely positive. So if it is NSMP ER diffusely positive, low grade, will there be any change? Now you see, actually, if you see this one, 2A low grade endometrioid invasion cervical stroma with NSMP low grade, there is yellow. It is in the yellow. So I think I will get 2 minutes extra time, and the system was not molecularly updated. So it's no one's fault. So if you see this one, stage 2, and if it is NSMP, this NSMP ER positive, it comes under the intermediate risk category. So you can easily, and if it is ER positive, low grade, then you can go like this. What about this case? Adequate surgery with lymph node dissection, myoinvasive, more than 50%, and again it is clear cell carcinoma, no substantial LVSI. If it is molecularly unknown, then it is myoinvasive and clear cell carcinoma. You will straightforward go for sequential chemorad or concurrent chemoradiation, whatever you practice. But if it is pole wild type, P53 wild and MMR deficient, what to do? So now, if you see, actually any high grade histology, myoinvasion, and if it is MMR deficient, you can come that this comes, I think it's not working. So it is again in the yellow group. So again it comes under the intermediate risk category. Then you can easily go for VBT. You can argue that as a medical oncologist, whether I will add immunotherapy in that or not, because it is MMR deficient. And keynote B21 has come, which has shown there is evidence of immunotherapy. But if you see clear cell carcinoma, overall it was around 10% in that study. And that too, this early stage clear cell was very less. So I am not going to add immunotherapy in this case, but VBT can be one of the options because now it comes under the intermediate risk. So if you see the intermediate risk, all these yellow colors are of intermediate risk, and if you see the treatment, mainly it is vaginal brachytherapy, it is practiced. So this was one of the important paper from Nanda Horweg and group from Netherlands. What they have shown, what is the impact of molecular classification on radiotherapy. If you see pole, there is no difference between EBRT, VBT and observation. If you see P53, you can see that EBRT was much better than VBT or observation. If you see MMR deficient, there was also actually not much difference between the EBRT, VBT and observation. But in the NSMP group, you can see that observation has done bad, EBRT, VBT almost same. So if EBRT, VBT is almost same and there is less toxicity with VBT, then you can easily go with the VBT rather than EBRT. So this was the impact of this paper. There is another case, I am giving 63-year-old lady, you can see the baseline MRI. It was 1B grade 2 with LVSI. 1B grade 2, fine, I can go for a VBT versus observation, but when it is 1B grade 2 LVSI, then you have to see that LVSI is focal or substantial. Now there is the ambiguity, and it is NSMP ER diffusely positive. So if you see the LVSI, it is an important independent prognostic factor, both in terms of recurrence-free survival and overall survival, proved in multiple studies. But LVSI is a challenge. Thrissur, some medical college pathologist is saying it is 3 vessel involved. Thrissur Medical College is saying 5 vessel involved. Amala is saying 4 vessel involved. And you are saying, according to the current classification, if it is 5 or more, then it is substantial, and if it is less than 5, then it is focal. If you say 1B grade 2, 5 LVSI, I am going for EBRT because it is coming under the high intermediate risk. And if it is 1B grade 2, 3 vessel involvement, I am saying that it is now under the intermediate risk and VBT will be fine. Problem is that in OTC environment, the system is different. There may be sampling error. That sample can be there for a long time. There may be cold ischemia effect. Somebody is saying 5, somebody is saying 4, and that is making huge difference. And if you see NCCN, they are saying 4 or more. CAP and International Society of Gynecological Pathology, they are saying 3. And now the current staging system, they are saying 5 vessels needs to be involved, then you can say it is substantial. If you see this paper, what they have done, they have measured the intra-class correlation coefficient, and they found that reproducibility of LVSI assessment and LVSI grading in endometrial cancer was substantial among the observer, and it was ICC was 0.62. So it was like a flip of a coin. If it is 0.5, then head or tail, 50% saying 5, other 50% saying less than 5. So 0.62 is not good. It should be 0.8, 0.9. Then I can be more robust, and I can say with more assurance. So if there is a substantial LVSI, low-grade endometrioid, then mostly it comes under the high intermediate risk category, and you have to go for a EBRT at least. This was a 10-year update of POTEC 3 results, and again you will find the impact of moleculars. If it is P53 abnormal, they have found that obviously rather than radiotherapy, when you have added chemotherapy along with radiation, it has done better in terms of overall survival and recurrence-free survival. You can see from the graph. Pole doesn't matter, but if it is MMR deficient, you will find that chemoradiation arm has done poorer as compared to the radiotherapy arm, and there comes the role whether immunotherapy needs to be added. NSMP, again you will find that chemoradiation done slightly better than the radiation, but in MMR deficient, chemotherapy has done poorer. So 67-year-old lady presented with postmenopausal bleeding, aspiration biopsy from endometrium, high-grade malignancy, CT heterogeneous mass in uterus, no distant mets, underwent robotic hysterectomy, bilateral salpingo-oophorectomy, and adequate lymph node dissection plus omentectomy, histopathology, endometrioid carcinoma grade 3. And now you see right parametrium was involved. So it immediately comes stage 3B disease. Now stage 3B means it is actually high risk, and if you see this trial, so in this patient I want to go for chemoradiation, okay, because parametrium was involved, but whether I will add immunotherapy or not, because I have seen that chemotherapy has done poorer as compared to radiation when chemotherapy has been added. So what this trial had showed, if you see the inclusion criteria, stage 1, 2 non-endometrioid histologies were there. Otherwise, it was stage 3, 4 and high-risk disease. What they have done, in one arm there was chemotherapy, and another arm they have added chemotherapy along with pembrolizumab, and radiotherapy was plus minus. 2/3 of the patients received radiation in this study. If you see the demography, you will find that stage 3 was 40%, and endometrioid histology 54%, non-endometrioid 46%, and a significant proportion of patients have got radiotherapy in this study. In overall population, there was not much difference when immunotherapy has been added with chemotherapy. In MMR proficient also there was not much benefit, but if it was MMR deficient, then you can see the disease-free survival 2-year 92% versus 80%, so immunotherapy helped. So this is our TMC experience. Year-wise, from very beginning 2020 or before, we have done MMR testing in all the cases. This was green. P53, you see from 2020, gradually it started increasing because there was some orange. Those cases we have not done MMR. With time, it increased. And poll status, 2024 we have done poll for all cases. So in our study, 350 patients, 33% were MMR deficient, 67% MMR proficient, P53, 25% had P53 abnormal, be it overexpression, be it mutated, be it null type. So overall it was around 25%. And poll, we have tested in 110 patients and 5 was poll mutated, variant of unknown significance was 1, so overall 6 patients I can say. And these was our poll characteristics, and from the very beginning when it poll was ultra mutated, we have not given any adjuvant treatment to those patients. And according to the poll status or molecular profiling, MDD decision changed after checking the poll. So you can see that case 2, where we have discussed VVT versus observation, after the poll came positive, we went to observation. Case 4, stage 2 grade 3 EBRT followed by brachytherapy was discussed, but when the poll came positive, then we changed to observation. Case 6 also, EBRT was planned but changed to observation. So thus molecular classification actually helped you. We found some double classifiers also, both P53 MMR, poll P53, poll MMR, all these combinations also we got. And we know that in endometrial cancer, always it is the lower profile, like poll P53, poll supersedes P53. MMR P53, MMR supersedes P53. So if you see our pattern of relapse, again you will find the patients who relapsed systemically more, they were actually P53 abnormal in our series also. And this was the pattern of relapse with P53 and different stages. So this is our data. At a median follow-up of 33 months, our 3-year overall survival according to poll, it was 100%, P53 87%, and MMRD NSMP it was 96, 97% in between. If you see the relapse-free survival, this is our TMC data, 33 months follow-up, poll 100% 3-year relapse-free survival, P53 75, and MMRD NSMP did slightly better, 91, 93%. So what is the example in real life? A patient has a surgery at one institution and their pathologic diagnosis is grade 2 endometrioid adenocarcinoma with more than 50% myoinvasion. There is focal LVSI, her nodes are negative. According to the FIGO 2023 system, she has been stage 1B grade 2. VVT has been offered in one hospital. The same patient goes to another institution for a second opinion. Pathologists there diagnose a tumor as a grade 2 endometrioid carcinoma, more than 50% myoinvasion with 5 lymphovascular emboli. Now she has been stage 2B according to the current classification, and EBRT, another hospital saying EBRT. She goes elsewhere for a third opinion. This institution offers molecular testing and her tumor is found to harbor a pole hotspot mutation, MMR proficient P53 wild type, and that doctor said you need not go for any adjuvant treatment. Think of the patient what he will do now. So this is one scenario, and adjuvant therapy for stage 3 and 4 pole mutant. This group, nobody knows the answer because this is still the gray zone. So for patients with FIGO 2023 stage 3 pole mutant and 4A pole mutant, due to limited number of patients, no firm treatment recommendations can be given. However, you need to follow them case by case basis. So still the environment is foggy and the sky is cloudy. You need the rainbow to get the horizon brightened, and this trial is going on in different verticals from blue, green, red, and orange. And this may answer many more questions. Thank you.
Any questions? Thank you for the wonderful presentation.
Stage 1A, 2 or 1B, all non-mutated, P53 abnormal. So based on
So based on the current classification, it comes under the high risk category.
Yeah, 2C,
So you will
MP3.
go for a full treatment like chemotherapy and radiation.
So now the POTAC 4 results are out last month. So whether you consider just EBRT alone or POTAC 3, you will plan for chemotherapy, because POTAC 4 looked into specific criteria where P53 abnormal will go for EBRT. So will you go for POTAC 3 or POTAC 4 in such patients?
So I am very clear about that, because if it is a P53 mutant, you are saying that it is myoinvasive and rest other things are negative. So this comes under the high risk category. You can follow according to your institutional protocol either concurrent chemoradiation or sequential chemoradiation, because there are many centers who are not practicing exactly like the POTAC, concurrent chemo followed by adjuvant chemo. Many centers are following sequential chemoradiation, but the message is very clear: you need both systemic treatment and external beam radiotherapy. There is no doubt about that.
And one more question, sir. So if you're practicing POTAC 3, the chemotherapy followed by chemotherapy, if the patient is having 3C2, will you consider parietic lymph node radiation after a complete surgery for the parietic lymph nodes?
After the complete surgery, if it is a parietic node positive
3C2.
in the histopath, so I will go for the extended field radiotherapy.
Thank you, sir.
Chemo followed by maintenance immunotherapy.
Yes, sir. So in this kind of one or two anecdotal case will definitely come, because mind it, all these whole trials what has been done, in those trials also some adjuvant treatment actually they got in that trial. Now we are saying that pole has extremely good prognosis and we are not giving adjuvant treatment, because when I discussed with the TMH people also, they were not very doing at that point of time that pole mutant, that means you go for a complete de-escalation. Later now they might have been started, and madam can tell us, but we started from the beginning, and our all 5 or 6 pole positive, pole mutant patients, they have not yet relapsed, sir. But obviously there will be chance of relapse, and you have option of the salvage. You can go for a salvage therapy.
ESCO guidelines made our work also easier. For stage 1 and 2, we are going for TH plus BSO. If it is high risk, we'll go for a infracolic or a total omentectomy. Otherwise we'll go for TH plus BSO. In stage 2 also, nowadays we'll go for TH plus BSO plus infracolic omentectomy. Along with that, we'll go for sentinel lymph node biopsy. But previously, we used to go, when it is stage 2A, we used to go for radical surgery. Nowadays we are going for simple hysterectomy plus in sentinel lymph node biopsy plus or minus infracolic omentectomy, so that the morbidity for the patient is lesser compared to that of previous guidelines.
Okay.
Thank you, Tabesh. That's the end of it.
With utmost respect, it's my honor to invite Dr. Tabesh Bhattacharya to kindly come forward to receive a token of our appreciation. Your valuable presence and insightful contribution have truly enriched this conference. May I request Dr. Francis sir and Dr. Priya ma'am to jointly present the memento. I kindly request the chairs to remain on the dais. Now I invite the next speaker, Dr. Jaya Ghosh, Professor Medical Oncology, Tata Memorial Hospital, Mumbai, to speak on ovarian cancer, somatic and germline testing in precision oncology. Ma'am, please.
Thank you, Francis sir, and the entire Aroicon team for this visit, and it's my first time in Thrissur, and thank you for the invitation. So, moving on from endometrial to ovarian cancer, I think to this audience, we all know that this ovarian cancer is not one disease, and even though today we are treating all ovarian cancers similarly, I think in future we will have a more directed therapy. And as for high-grade serous ovarian cancers, even though only 15 to 20% of them have germline BRCA mutation, about half of them have BRCA-NES. And we had very high hopes, and a lot of things have changed with the advent of PARP inhibitors because of synthetic lethality. So when BRCA is mutated and the cells can't repair their DNA, blocking the PARP inhibition causes synthetic lethality, and therefore the use of PARP in these subgroup of patients. So what I just want to do at this stage is that we know that several of the genes are involved in the HRR pathway. So the HRR pathway, in addition to BRCA1 and 2, also constitutes of PALB2, RAD51, ATM. So there are several genes which are involved in the DNA repair pathway. So even though several of these genes are involved, the HR deficiency, that is the functional deficiency of the cell to repair a DNA, may not be there. So if a patient has a BRCA mutated tumor, so that patient's the DNA cannot be repaired. So it will always result in a functional HR deficiency. But suppose there is a non-BRCA mutated mutation, meaning that suppose there is a PALB2 or a RAD51. So that does not mean that it always will cause HR deficiency. So HRR pathway mutation is not always equivalent to HR deficiency, and that is something we need to remember, because that has implications in our treatment decisions when we do the test. So the HRR is the cause, but the cause always may not lead to the effect. So the HRD, we are testing downstream pathway, looking at whether the cell can actually repair the DNA or not. So we do need to remember this difference. And how do we measure this HRD? That is the ability of the cell to repair. That is, so we are looking at the downstream effect. So this could be loss of heterozygosity or large segment deletions or telomeric allele insufficiency. So just to remember that about half of the ovarian cancers are HR proficient. The rest half are HR deficient, as we already saw. But among these half which are HR deficient, there are some which have a pathogenic mutation. But there are some patients who have HR deficiency even without an HRR pathway mutation, because as we saw previously, some of them can have DNA which can be hypermethylated, and that could also lead to the cell having a property which is like HR deficiency. So what is important are two things. One, whether the patient has a BRCA mutation or not, because if a patient has a BRCA mutation, that definitely means that they cannot repair DNA and they are HR deficient. Second is we look for HRD. Now, if a patient does not have BRCA mutation and is HR deficient, then it does not matter whether or not they have a mutation in any of the other genes like PALB2, ATM or RAD51, or it is because of hypermethylation, because the net effect is that they can't repair the DNA. So, and why this becomes so important is because of the implications for different cancers. Of course, today we are dealing with ovarian cancers. In ovarian cancers, the approval for PARP is if they have a germline or a somatic BRCA, or if they have HR deficiency. So that means what? That if a patient has, if somebody does a tissue testing for HRR and it comes as RAD51C positive, but the HRD is negative, would they benefit from PARP? The answer is no. So therefore, when we are sending for testing, we need to know whether we are sending germline testing or whether we are sending somatic or HRD testing. So that is there. Whereas, something like prostate cancer, it is approved. So for prostate cancers, if a patient has a somatic HRR mutation, it is approved. So that's where these differences come for. So we need to know which cancer and what indication that. And for breast, it is only germline mutations which are indicated. So therefore, we have three kinds of testing: the germline BRCA1 and 2, the somatic, and the HRD testing. So what we need to know that the somatic HRD testing also includes the somatic BRCA. So if you're sending for an HRD testing, that by itself includes the somatic BRCA. So as compared to the previous, the recent guidelines, they say that all epithelial ovarian cancers should be offered genetic testing. Germline testing should be offered to all, because irrespective of treatment implications, it has huge implications for the family and cascade testing. And somatic testing is only if I have a treatment implication that is like in advanced cancers, and that is something that needs to be done. Patients with clear cell endometrioid and mucinous can also harbor MMR deficiency, and therefore that is something which should be done. We should also take for MMR testing in these patients. And previously we thought that only those patients with a family history of ovarian cancers they should do, but we see that close to 20% of patients even in Indian population did not have a family history of ovarian cancer. So if we test germline for only those who had a family history, then we will be missing out on a large number of patients, and therefore at least germline testing is irrespective of the family history. And as I discussed that apart from, of course the highest incidence of BRCA mutation is present in those who have high-grade serous, but there is a small incidence even in low-grade serous or the endometrioid. So it is only the mucinous variety where it is really not there. So if you have a mucinous tumor, you don't need to send for BRCA, but then you do need to send for at least test MMR in these patients. So then we come to the question, what should we test? Should we do somatic first, then do germline, or should we do germline first and then do somatic? Because that's always the question which is there. So germline testing is more sensitive, and if germline is negative, there may be 5% of patients who may still harbor a somatic mutation. And the same is true the other way around, and I'll show you some of the more recent data where if you do a somatic first, we have almost a 5 to 10% chance of missing out a germline mutation. And missing out a germline mutation would be very difficult, because then we would miss out the opportunity not only for that patient but for their testing for their family members. And when we are doing a germline testing, it is preferable if we do the entire panel, because then we would be able to pick up the other MLH1 and the other MMR and the other HRR pathway genes. So for germline testing, when we are doing, a panel may be preferable to do. Although that also, if you increase your panel size, the chances of finding a VOS also increases. So therefore, I think most of the guidelines are coming to the fact that we do germline testing first, and if the germline testing is negative, then we go ahead with testing for somatic. Although there was some thought whether we should do both together, but that would definitely increase the cost. So if you did germline testing first, you would need to, about a third of patients, you would also need to do the testing for somatic testing. So if I do germline testing first, I'll end up needing to do both tests twice, whereas if I do the other way around, that if you test all patients for somatic and then do the germline, you would need to do it dual testing in a less number of patients. But the major concerns of patients that why should we do germline first is because if somebody does a testing on the somatic tissue, they basically miss out on a large segment deletion. So if there are large segment deletion, then doing the test on the somatic tissue, they will not be able to pick it up. And therefore, we will be missing out in different studies anywhere between 10 to 20% of these patients, and we know that has the most robust implication. And of course, this was an interesting study where they did both together. And even in the best of the centers, after referring only about a third of patients, they don't go for the genetic testing or counseling. And this, okay, and another problem which comes with the somatic testing is that the tissue may not be adequate, and we so many times see that if especially if you've done a biopsy, there we may get the tissue is not adequate or the sample is not adequate. And similar problem comes up if you take a post-neoadjuvant chemotherapy sample and there is a lot of necrosis and not much tissue. So there again, doing a somatic testing may become difficult. So of course the turnaround time is higher if you do genetic first and if it comes negative and then you go for somatic. So it is best that when the patient initially comes, we send them for germline testing. And by the time of their surgery, if it is an advanced disease, then we would get to know their genetic report and then decide on somatic testing. So it is best done on the baseline tissue if that is adequate, and of course have more blocks at the baseline. Okay, so this was an important a study which looked at both of them together, and as I mentioned that there is a higher rate of failure in those who undergo a biopsy, almost 22%. And only 2% of patients with pathogenic variants would be missed if we did a germline testing first. So, less chances of missing out if you do a germline first. Okay, so what about HRD testing? So HRD testing, as I said, was the functional assay. So that would look at somatic BRCA as well as other HRR pathway, but whether they are having an effect or not. So HRD is the downstream effect, and that is to be done only if I have a treatment implication. So HRD should not be done for somebody maybe who has a stage 1 disease, because we know that that is where PARP is not indicated. So only if we have a indication for treatment, only then at that point it should be done, and it should not be done as a routine for all patients. So if a germline is negative, patient is frontline, has advanced stage disease, high grade, and has an implication for PARP, that is when we would do an HRD testing. So as was mentioned, all HRR is not equivalent to HRD, and there is no, it is not, it does not have an implication therapeutic in, HRR does not have a benefit in ovarian cancers giving PARP. So then we come to, there are various HRD tests which are available to us. So few of them have been standardized. The standard has been the Myriad MyChoice, and we also look at what cutoffs they have used. The Myriad MyChoice had used a cutoff of 42. So at TMH we use the Sophia diagnostic, where the cutoff is, anything 1 or more is considered as positive. So it is important to know which HRD testing we are using and what cutoff has been used. Like if somebody is testing only the loss of heterozygosity, then the cutoff is 16. So it is important to know when we are doing HRD testing, which test and what cutoff, and has that been validated? That's the most important question. So just because we discussed so much about these tests, just quick this thing on the implication is that we are all aware that in patients with advanced epithelial ovarian cancers, presently we have mainly the PARP inhibitors and the bevacizumab, which we use as maintenance strategies. And we have had several studies which have shown a huge improvement in progression-free survival and overall survival, and especially if they are germline BRCA positive. Now I will just go to this. The initial landmark paper was that for SOLO-1 study, where they had shown a huge benefit from 13.8 to 56 months, and the overall survival continued to show a benefit. And about half of these patients completed their 2-year therapy. So even if you look at 5-year, there is a difference in survival from 63 to 73 months. But remember, these are germline BRCA mutated patients, although they had taken both germline and somatic, but close to majority of these patients had germline BRCA mutations. So when we are looking at the results, we should know which population these results apply to. Of course, we are all aware of their side effects, especially MDS, but that is only in 1% of these patients. And a lot of these patients also have fatigue and anemia. And important thing is that anemia doesn't always happen in the first or the second month. Sometimes patients, after they continue treatment for 3 months, then they suddenly come back with a hemoglobin of 4 or 5. So it is important we just can't leave them when they are on the PARP inhibitors. We need to monitor them monthly and initially maybe even weekly, because sometimes they just come back with grade 3-4 toxicity. And this was work done by one of my colleagues where they did a meta-analysis of all these patients and patients who received frontline PARP inhibitors. And their benefit was seen mainly in patients who are BRCA mutated or had a HR deficiency. For patients which HR proficient, there was absolutely no difference. So important to know that, now that we have the overall survival results of the other studies, we see that, if you look at the differences, this is again the maximum differences in patients who have germline BRCA mutated, even over in their overall survival. And same, this is again a graph which are HR deficient. For patients who are HR proficient, there is no difference. In fact, there is a detriment in survival. So therefore, we have to be very, very sure as to, the 5-year OS is just the reverse. You look at 25% versus 32%. So for a HR proficient patient in frontline setting, there is no role of PARP inhibitors. And similarly, we have data from the niraparib or the PRIMA studies. In fact, here, if you look at the overall survival for all patients, it's almost the same. So unlike, the two where they had shown, and even for an HR deficient patient, it was same. And same for, of course, in the HR deficient but BRCA wild type. And again, in HR proficient, it is just the reverse. So although olaparib has shown both a PFS and an OS benefit in patients who are germline BRCA mutated, and in POLA with BEV, even in patients who are HR deficient, the other trials have shown a PFS benefit, but not an OS benefit. So some say that, why it has not shown an OS benefit is because some of them got PARP inhibitors, and they say that there is a meaningful PFS benefit, like patients don't relapse for a long time, even though once they relapse, then their outcomes are actually poorer. So because they no longer maybe remain as sensitive to platinum as baseline. So we know that platinum sensitivity is a surrogate for PARP sensitivity. And similarly, when patients relapse on PARP inhibitors, their platinum sensitivity is less than what you would normally have. So therefore, we have to be very, very careful in choosing patients whom we use adjuvant PARP for. Definitely in the frontline germline BRCA mutated, yes. Germline BRCA not mutated but HRD deficiency, yes. But maybe knowing that, it may not always translate into a survival benefit, but there is an increased PFS benefit. So, this is just a small algorithm that we thought that, if this is germline somatic BRCA mutated, then we definitely go for PARP. If it is wild type, then we do an HR testing. And if they are HR deficient, then we go for PARP, but plus minus bevacizumab you might add. But if there is a HR proficient, then definitely I think observation would be an option if they have been optimally cytoreduced and there are no high-risk features. Whereas if they are stage 4 or not optimally cytoreduced, those patients would be a candidate for bevacizumab. Just 2 more slides on, how initially we all get very excited about a new drug. So so all this that I told you was in the frontline setting. If I come to the recurrent setting, patients who have received 2 or more lines of therapy. Previously, single agent PARP inhibitor was approved. Presently, the approval has been withdrawn because single agent PARP compared to chemotherapy had shown an improvement in survival, but all this red bracket from 2014 to 19 approved, and then 22, 23 all approvals withdrawn. And the reason why all approvals have been withdrawn is because they have shown actually a detriment in survival. So if there is a detriment in survival, even for patients with germline BRCA, so so therefore we need to remember beyond second line, no PARP. And these are all, if you look at here, it is just the reverse, 19 versus 25 months. So there is a huge detriment in survival, therefore it is not approved, all approvals withdrawn. And in the first line recurrent setting, that is patients who first time platinum sensitive relapsed, the approval has, previously it was anybody who has a response give PARP. No. Presently it has been narrowed down to only those who are germline BRCA mutated. So if you look at this, so current approval in first line recurrent setting is only in those who are BRCA positive, germline BRCA positive. And the reason being that, again, if you look here, there is a detriment. You know, if they're HRD positive here, also it doesn't matter. The overall survival is worse, 36 months versus 44 months. So bottom line is that in a recurrent patient, if they don't have a germline BRCA mutated, there is no need for HRD testing because there is no benefit of giving PARP to these. I mean, they may show a progression-free survival benefit, but after that, when they relapse, they do worse. And their overall survival is actually detrimental. So that is important to remember because that is something which has changed. And the main reason being that, as I mentioned, that once they relapse, they actually do worse. So the ones who had received PARP do worse. So I would think that yes, germline testing for all patients, somatic and HRD testing only in the front line because that's where it is going to make a difference in our management. That's it, I think. Thank you.
Thank you for the very clear presentation. We can have one or two questions.
Morning, ma'am. How will we counsel, especially young patients, when we start PARP regarding second malignancy?
So because the incidence of second malignancy in the frontline setting is 1 to 2% only. The incidence is more when we're using it in the recurrent setting. There it is close to 8% overall. So that's close to almost 1 in 12 patients. So therefore that is a higher risk. So when we do tell patients, I tell patients that, you know, overall there is a survival benefit, you know, instead of the disease coming back in 2 years, you know, it's likely to come back. I mean, we don't say come back, but when we say that, you know, disease is likely to be under control for, you know, an extended period of time for like, you know, close to 5 years. But although in my personal because we have started, access to PARP has become more accessible over the last couple of years. I'm yet to see, you know, those 5-year survivals that they are shown, but you know, that's what the data is. And I do inform them that that we need to monitor, but I don't emphasize, I just mention that, you know, there is a small risk of 1% risk of having a blood cancer, but there is a higher risk of disease coming back. So I think that is what we tell them. So
the incidence of leukemia is more during second line just because of longer duration of exposure, or?
Yes, longer duration of exposure both to PARP inhibitors as well as, you know, of course they have received 2 lines of therapy, and important is that it is not only 4 years and the risk continues even after they have stopped the PARP inhibitors. So it is initially 4 years, but even after stopping, the number of people who are getting MDS and AML is much higher. And one important thing to suspect it is that when patients are repeatedly getting low counts, we are needing to repeatedly stop it. That is when we should kind of suspect that they are having an AML or an MDS, and we do check their differential counts. So that is one clue that they could have. Sometimes we've done patients, we've seen, even done a marrow, there was nothing, but we stopped PARP because they were getting repeated cytopenias. And then after a year or 2, they've developed a frank leukemia. So even if you don't get it at that time, you know, they develop it later. And once they get a therapy-related leukemia, it's very difficult. I mean, we can't treat them. It becomes largely only palliation.
Madam.
Mm-hmm. So, okay, so the patients who have brain metastasis even before the PARP, although there are few patients, for some reason they don't have any other systemic metastasis. But if they have progressed on PARP, I do not know how much they would benefit by continuing the. Uh, but after stopping for how long? So, okay, so those cases probably giving another platinum is what I would think. Yeah, sure, I understand. There is some data for use like Oreo PARP after PARP, but that is a very limited data. And now that we are moving more towards this thing that is there.
But germline BRCA testing, if it is positive, we'll go for risk reduction surgeries for patient. Suppose if somatic BRCA is positive, any difference in management?
No, so if somatic BRCA is positive, we would have to do a germline BRCA testing, and only if germline is positive will we go for any other risk reducing surgeries. Somatic per se is not an indication for this, so we have to go back and do a germline testing.
Thank you very much.
It's my honor to invite Dr. Jaya Ghosh to kindly come forward to receive a token of our appreciation in recognition of the enlightening and thought-provoking lecture. May I request Dr. Francis sir and Dr. Priya ma'am to jointly give them a memento. We would also like to acknowledge our respected session chairs, Dr. Francis V. James, Professor in HOD Radiation Oncology, RCC Trivandrum, and Dr. Priya V., Associate Professor, Department of Obstetrics and Gynecology, GMC Thrissur. We request Dr. C.S. Madhu sir to kindly hand over the mementos to the session chairs. We kindly request all delegates and faculties to check out from their place of stay by 12 p.m. Now may I request Dr. K.L. Jayakumar and Dr. Shabrinath P.S. to kindly take the chair for the memorial oration. Sirs, please. It is now time for the Professor A. Sudhakaran Memorial Oration. He was born on 5/6/1953 and he joined the service on 4/3/1980. Served as a Professor of Radiation Oncology in Medical College Kozhikode and he retired on 30/4/2008. And since then he was in MCH Pariyaram. He worked in various government medical colleges. He was a great teacher and was up to date with developments. He cared for his colleagues, trainees and other paramedical staff. He expired on 16th of June 2021. I now invite Dr. Pushpaja K.U., Associate Professor, Radiation Oncology, Amrita Hospital, Kochi, to deliver the talk on Survivorship in Head and Neck Cancer, Redefining Care Beyond Cure.
Very good morning to all. Respected chairs, Sabrina, Aroy Secretary, Jaykumar Sir, Aroy President, my teachers in the venue, Jaykumar Sir, Shashindran Sir, Prema Madam, all are my teachers, and senior faculties of the dais, my colleagues and dear friends. Let me first share my memories of personal interaction with Sudhakaran sir. Actually in 2006, I joined Calicut Medical College for the DNB. During that period, sir was HOD there. Sir was an excellent teacher, great academician, and sir was a good clinician also. He had a lot of empathy to the patients. And I remember sir taking a lot of evening classes for the PGs. Dr. Renu will be knowing about it. She was a student. I was fortunate enough to attend some of the classes in just 2 weeks of my time in Calicut Medical College. Sir used to take classes from 7 o'clock and it would extend up to 10 p.m. And it's a great loss that Sir left all of us so early. It's a loss to the Kerala Aroicon fraternity. When I got admission in Amrita, I was so afraid to ask Sir, but without hesitation, Sir permitted to go to Amrita. So I'm always grateful to Sir for that gesture. So let me now express my thanks to the President Aroy, Secretary Aroy, Francis Sir, our Scientific Committee Chairperson, Organizing Committee Chairperson Prema Madam, and Secretary Dr. Ajit for giving me this opportunity. When Dr. Shabrinath called me 2 weeks ago, just 2 weeks ago, for asking for the oration, I was so confused what to select. I was working in head and neck unit for the last 10 years, so I wanted to select a topic in head and neck. So I was discussing with my friends and colleagues. So it was Dr. Shiga Goyal, Associate Professor, PGH Chandigarh, who immediately texted me 2-3 options. So one was survivorship in head and neck cancer. So I was also interested in doing this because it's less addressed in the conferences. And thanks to our Senior Registrar, Dr. Pranav, for giving me a nice title to the topic. So let me go through the presentation. So the contents will be the incidence and who is a cancer survivor, what is cancer survivorship, evolution of cancer survivorship, cancer surveillance, and other guidelines related to the survivorship. So as you all know, it's head and neck cancers arising from the oral cavity, pharynx, larynx, salivary glands, nasal cavity, and paranasal sinus, and etiology and other predisposing factors, presentation, natural history, and treatment outcomes, all of us know. 90% is squamous cell carcinoma arising from the mucosal lining. The incidence in India is increasing. It's a major public health problem. It accounts about 30% of all cancer cases. The all-site cancer incidence, according to the paper given below, is 26 per 1 lakh population of males and about 8 per 1 lakh population in females. So as you can see here, there is a comparison of all-site cancer burden with head and neck cancer burden in India. It's from the various public registries. In Northeast, you can see it's high in males and females. And so coming to the treatment, as we all of us know, early it's single modality and advanced is multimodality. And always there is a lot of side effects associated with the treatment. And now the treatment paradigms are evolving to reduce the toxicities. Less invasive surgical techniques like robotic surgeries has come. Newer techniques in radiation and also new contouring guidelines like what we have discussed yesterday. And also there are a lot of de-escalation trials going on in oropharynx HPV positive cases. And also there is integration of targeted therapies recently. And we all of us know that there are a lot of side effects in spite of all this. So the side effects affect the cancer survivors' functionality, quality of life, mental, emotional well-being, and financial stability. And also the increasing number of survivors and longer duration of survivorship, there is complex need for greater emphasis on survivorship care. So once again, the early detection, the novel, increasingly effective therapies, improved therapeutic care, there is an increase in cancer survivors, and so therefore there is a need for survivorship care, and also it's a new trend of focus of research in oncology. So who is a cancer survivor and what is cancer survivorship? The concept of cancer survivorship, it is traced to an article published in NEGM in 1985 by Dr. Fitzhugh Mullen. He was one of the founders of the National Coalition for Cancer Survivorship. He was a physician and himself a cancer survivor. So he wrote, the challenge in overcoming cancer is not only to find therapies that will prevent or arrest the disease quickly, but also to map the middle ground of survivorship and minimize its medical and social hazards. And he also wrote that there are 3 seasons of survival. Acute survival, that's a period of diagnosis and treatment. Extended survival, period that begins at treatment completion and including the surveillance. And there is a permanent survival period which is vaguely defined as cure. So after that, in 1996, the National Cancer Institute established an Office of the Cancer Survivorship. It adopted the NCCS definition of a cancer survivor. So cancer survivor is an individual who is considered an individual is considered a cancer survivor from the time of diagnosis and through the balance of his or her life. According to this, the family members, friends, caregivers are also impacted by the survivorship experience and also included in this definition. It was a debatable thing, but even then it is included in the definition. So after that, in 2005, a National Cancer Policy Board published an article. It was as per the report of the Committee on Cancer Survivorship, Improving Care and Quality of Life in Survivors. So this is, it's actually a book-like thing. So from cancer patient to cancer survivor lost in transition, that was the title of the book. So in this, a survivor is an individual as well as his or loved ones living with, through and beyond a cancer diagnosis. And it was divided into phases: acute, extended and permanent. So acute will be during the initial treatment, extended during the recovery and adaptation to a new normal, and permanent long term. My talk will be basically based on this extended and permanent only. So survivorship can be targeted to one or many of the phases as mentioned above. The report also focused on survivors during the phase of care that followed the primary treatment. The recommendations were for raising the awareness, defining the quality of health care, and improving the quality of life of the cancer survivors. So after that, so many guidelines came. It was the American Cancer Society who published. It's mainly to most of the guidelines are for head and neck cancers. The first one was by the American Cancer Society, that is in 2016. Then ASCO in 2018, American Head and Neck Society in 2021, European Head and Neck Society in 22, and ESMO and NCCN guidelines are also there, but it's for all sites. And NCCN, I don't know, I'm not very sure when it's gave the first one, but yearly it is keeping on updating. So the first was American Society Cancer Guidelines. It was given by Cohen in 2016. So the guideline was developed to assist the primary care physicians and other health practitioners caring the head and neck cancer survivors. And the recommendations were given for monitoring the recurrence, screening for the primary cancers, for second primary cancers, assessment and management of the long-term and late side effects, health promotion and care coordination. Long-term effects are just starting at the treatment time and which is extending throughout the life, and late effects are starting after the treatment and extending throughout the life. So after that, an endorsement summary was given by the ASCO by Neclew Dev. In this, they gave so many models of survivorship. Actually, all the guidelines after this is based on this paper. So in this, the ASCO emphasized the role of multi-speciality, multidisciplinary care of the head and neck cancer survivors. So it included the it was a teamwork which included primary care physicians, oncologists, otolaryngologists, dentists, speech therapists, dietitians, physical therapists, mental and health professionals, and other supportive care experts. And then in 2021, the American Head and Neck Society guidelines came. So in this, the definition for cancer surveillance and cancer survivorship was separated and clearly mentioned. So cancer surveillance will be for disease, surveillance of the disease recurrence, progression, second primary cancers, often during the first 5 years after treatment completion. And survivorship is a broader concept of lifelong care, including all the interventions and consequences of the cancer treatment, including the physical and psychosocial effects of the survivors, coordination of care between the primary health providers and specialists, and also the prevention of new cancer and late effects, and also the survivorship care planning. And so many recommendations given. I'm not going to the details of each recommendations as per this paper. And now in 2022, ESMO expert guidelines also came, but it is for a general, it's for general sites, not for head and neck. And in this, 5 sets of recommendations were given. And it also gave the key priorities and strategies to be followed for survivorship. The needs will be meet the needs of the cancer survivors, improve and implement the survivorship care, and also the importance of the coordinated research and coordinated care in this. And in 2022, the European Head and Neck recommendations was published. And as I mentioned earlier, the NCCN guidelines are also there, which is updated yearly. And in this also the standard of survivorship care is given under 5 headings. And in 2025, this novel survivorship paradigms in head and neck cancer got published in seminars in radiation oncology. My talk will be based on this paper mainly. So in this 5 domains of cancer survivorship was described. It was basically based on the Neck-Lido model, which was mentioned in the endorsement summary. And 5 domains were explained like in different headings, like prevention and surveillance of recurrences and new cancers. The second one, surveillance and management of physical effects, surveillance and management of psychosocial effects, and chronic medical conditions, health promotion and disease prevention. We'll just go through quickly each of the guidelines. So here you can see the circles, all the 5 domains, and there is a rectangles beyond that, which represent the broader factors that impact the patient ability to receive comprehensive survivorship care. So we'll just go through each one. Prevention and surveillance of recurrence and new cancers. So as mentioned earlier, cancer surveillance definition was given, and what we do in the surveillance period, all of us know that regular follow-up is essential, which includes history and physical examination, and wherever possible, wherever required scopy, appropriate imaging. One of the important blood tests will be thyroid function test, and also other ancillary tests like emerging molecular biomarkers wherever needed. And follow-up is, according to the guidelines, follow-up will be 1 to 3 months during the first year, 2 to 6 months in the second year, 4 to 8 months in the period 3rd to 5th year, and yearly after that. What are the guidelines for imaging? Routine, you will be doing an immediate post-treatment period in 3 to 6 months. So after that, should we do an imaging? That is a question. But the routine surveillance imaging in asymptomatic survivors is controversial. So it is due to the limited evidence of the survival benefits, and also there is a chance of lot of false positivity, and following which so many unnecessary procedures will be taken. So according to the guideline, it is reserved for specific population, patients who have worrisome signs and symptoms and has a history of smoking, that is for lung-related imaging for ruling out second primary cancers. And areas inaccessible to clinical examination, head and neck, like salivary glands, nasopharynx, and base of skull primaries. So, what are the other strategies? The one is HPV DNA testing, which is a promising biomarker for early detection of recurrence. And in cancer screening, based on the survivor's age, gender, and risk factors, investigations are decided. So, elevated risk of second primary malignancy, especially in lung, with a history of smoking. The NCCN recommends chest imaging, low-dose chest CT without contrast, as clinically indicated for patients. Now, second will be the surveillance and management of the physical effects. So, we know there are a lot of physical effects to the patient after treatment. So, during the follow-up visits, you can assess the mobility of the shoulder, temporomandibular joint, and neck. Patients will be having leg stiffness, difficulty in mouth opening due to the TMJ issues. So, necessary guidelines we can assess, and necessary guidelines we can recommend. And also serial recording of the maximal inter-incisor distance, and also ensure mouth opening exercises to reduce the trismus related symptoms. Lymphedema, that is a common side effect. So, lymphedema management is also an important thing. Complete decongestive therapy is the gold standard in this. So, it includes manual lymphatic drainage, advising neck exercise, and good skin care. One of the other important complications is dysphagia. So, it is based on the study by the SEER. The prevalence of dysphagia will be around 45%. Stricture can happen in 10%, and aspiration pneumonia is also there, around 8%, according to this paper. Always dysphagia management is important. It should be started at the start of the treatment and continue throughout the survivorship. Swallowing exercises throughout the treatment phase are associated with better long-term swallowing outcomes and reduced tube dependence. So, a good support from swallowing team is essential throughout the treatment and during survivorship. Speech is another important thing pertaining to the head and neck cancer treatment. So, it has significant psychosocial implications and lead to a significant impact in patients' quality of life. So, early referral to the speech and language pathologists is also important. Another thing is patient-reported outcomes and quality of life assessment during the survivorship program. So, routine incorporation of all this has shown to improve the survival and health-related quality of life. And we have already quality of life assessment tools like HN30 and HN35, but now the FACT HN-RAD has come, measuring the radiation-related toxicities. So, third domain will be the surveillance and management of the psychosocial effects. Always the mental health needs are less addressed in the survivorship program, but it's very important. Most of the patients are vulnerable to the psychological morbidity, stigma, loneliness from social isolation. So, reported incidence of depression is about 15 to 50%, and for the current guidelines emphasize the importance of regular screening for distress, depression, anxiety, and there are various tools also, and if necessary, psycho-oncologist services support should be ensured. And those survivors having depression are more likely to experience inferior disease specific and overall survival, according to the paper published in 2016. And some of the patients will be concerned with body image, and also they have lack of sexual function and intimacy. So, wherever necessary, psychosocial therapy has to be given to address all these issues. One of the other major concerns is financial toxicity. After treatment, so many patients will be having financial toxicity, and it also leads to psychological distress. So, some of the patients will not be able to return to work also. So all of this leads to so many issues. So it has to be given proper advice regarding all of this. Early returning to work, motivation should be given to all these patients. And fourth domain will be surveillance and management of the chronic medical conditions. There are a lot of comorbidities associated with the disease treatment, like dysphagia, malnutrition, weight loss, aspiration pneumonia, anemia, dental caries, and ORN. So all this increase in incidence within the first year and continue to increase the probability throughout the survivorship. The most common will be dental issues, and so necessary dental extractions should be given under proper help from the concerned dental consultants. And also there is a 2024 updated guideline regarding this. And during survivorship, the other cancer related morbidities and morbidities should also be dealt with. Cardiovascular disease, due to the exacerbation of the hypertension, increased risk of stroke, myocardial infarction. All this can lead to mortality of the patient also. So you know that carotid stenosis can happen in long-term side effects. So carotid ultrasound screening may be considered in such patients to avoid the thromboembolic phenomena. The fifth domain will be the health promotion and disease prevention. So counseling regarding the smoking cessation, alcohol consumption, nutrition strategies, and regular physical activities should be done. And also should recommend a dietary pattern as per the dietitian advice. Now, how do we implement a survivorship care plans? A survivorship care plan should be given at the end of the treatment by the oncology team. It includes a treatment summary and a follow-up care plan with regular instructions for follow-up. The timing of the follow-up scans should be clearly written, and the laboratory tests to be done, and also the risk and late effects of cancer treatments should be explained. How do we go for the survivorship care? There should be multidisciplinary survivorship clinics, including all the teams like oncologists, dental consults, speech and swallowing therapists, dietitian, physical therapists, social workers, primary health care providers, and deliver a coordinated and holistic care of the survivors. So last, let me just go quickly through the table given in this paper. All the guidelines are given in this based on these 5 domains, but it's more or less the same. I am not explaining each of the thing. Interested people can go through this in the paper. So it's all the important guidelines related to head and neck on this 5 domains are given in this: cancer surveillance, physical effects, psychosocial effects, then chronic conditions, and health promotion, care of coordination and practice implications. What are the recommendations given each of the guidelines? More or less it is the same only. Now coming to the end of the talk, the take-home message will be long-term care of the head and neck survivors is complex and requires coordination among the multiple providers. 5 domains of survivorship care is there, and the key recommendations from the different head and neck organizations and societies. And further research is required in the survivorship. Thank you, everyone. In Amrita, we have a PG thesis on dysphagia, and one of Dr. Pranav has already done a distress management relating to survivorship. And also we have quality of life assessment and trismus management.
Thank you, Pushpaja, for taking up this important topic. It's a very novel topic. Actually, selecting the topic itself is a good gesture, because I am also hearing this for the first time. and you have good clarity of your presentation, what you have done. Talking about Professor Sudhagan, also you remember him very well. He is a gentleman, excellent clinician, and very kind-hearted sir. And as you rightly said, his main habit is reading, especially Divita, page by page, he remember, and the topics also. And as I still remember, he was the first person to buy a Divita when it was published first during late 80s. So that was his reading habit. And always he'll be teaching, morning teaching, forenoon teaching, and also night classes. And his colleagues are also forced to attend his class. Keeps on asking questions. Such a kind-hearted gentleman. You remember him. And thank you for taking this topic. And the presentation was good. Thank you so much.
Thank you, sir.
Nothing more to add, madam. ഒറ്റ വാക്കിൽ നിർത്താം. ഈ പറഞ്ഞ വാക്കുകൾ എൻ്റെ അധ്യാപകനാണ് പറഞ്ഞത്. ഞാൻ ജോയിൻ ചെയ്യുമ്പം എൻ്റെ HOD ആയിരുന്നു. അപ്പം എൻ്റെ അധ്യാപകനെ കുറിച്ചാണ് സാറ് പറഞ്ഞത്. അപ്പം ആ ഒരു സെഷനിൽ ചെയ്യാൻ കിട്ടിയ ഒരു അവസരം ഞാനൊരു വളരെ ഭാഗ്യമായി തന്നെ കാണുന്നു. പിന്നെ മാഡത്തെക്കുറിച്ചൊരു ചെറിയൊരു വാക്ക്, നിങ്ങൾക്ക് പലർക്കും അറിയാൻ മേലാത്തൊരു ചെറിയ കാര്യം. വൺ ഓഫ് ദ സീനിയർ മോസ്റ്റ് മെമ്പർ ഓഫ് അറോയ്. ഇപ്പോൾ ഇവിടെ ഇരിക്കുന്ന അതിനേക്കാളിലും മാഡം അത് പറയുന്നില്ലാതേ ഉള്ളൂ. എനിക്ക് തോന്നുന്നു ഇപ്പോൾ ഇരിക്കുന്നതിൽ വൺ ഓഫ് ദ മോസ്റ്റ് സീനിയർ സുരേഷ് സാറിനെ കൺസിഡർ ആകട്ടോ. സാർ നമ്മുടെ 10 വർഷം സെക്രട്ടറി. ഞാൻ പറഞ്ഞതെന്ന് വെച്ചാൽ അത്ര സീനിയർ മോസ്റ്റ് മെമ്പർ ഓഫ് അറോയ് ആണ് മാഡം. മാഡം അത് സത്യം പറഞ്ഞാൽ മാഡം എപ്പോഴും അവതരിപ്പിക്കുമ്പോൾ അതൊരു എളിമയുടെ ഭാഗമാണ്. ഞാനൊന്നുമല്ല എന്ന് പറയും. അങ്ങനെയല്ല, നമ്മുടെ അറോയുടെ ഒരു ഭാഗവാക്കും ചേർക്കും.
Thank you.
Thank you. I kindly request Dr. K.L. Jayakumar sir and Dr. Shabiranath PS to hand over the memento to Dr. Pushpaja ma'am. I kindly request Dr. Suresh Kumar K to hand over the mementos to the session chairs. Sir, please. This is to announce that the session on Beyond Exam, Careers and Training in Radiation Oncology has started in Hall B. We also kindly request all delegates and faculties to check. I kindly request Dr. Anup R, HOD Radiation Oncology, AIMS Kochi, to kindly hand over the memento to the session chairs. Sir, please. We shall now break for tea. Tea is served in the outside corridor. Kindly assemble in the hall by 11:30 a.m. sharp as we will resume the next scientific session of systemic therapies with radiation in node-positive prostate cancer.
Good morning all. Thank you, chairpersons. Thank you, Francis sir and the organizing committee of Can Kerala Aroicon 2026 for giving me this opportunity. I'll be talking about integration of systemic therapies with radiation in node-positive prostate cancer. So I will not be touching the radiation part. It will be only the addition of systemic therapy. So, node-positive prostate cancer actually has three groups. One is pathologically node-positive, that is for a patient who has undergone radical prostatectomy and pelvic lymph node dissection along with radical prostatectomy. The pathological node-positive patient is node-positive patient in CA prostate, that is pathologically positive. Second group is clinically positive, that is by imaging. And my talk is concerning the second group. Then there is a third group, which is imaging. There is node negative, but there are certain features which are included in certain nomograms which predict the possibility of node positivity. And they have defined a significance score of around 15%, which should be considered if that predicts the possibility of node positivity. So the first group is pathological, second group is clinical, node positivity, and the third group I can say is more of microscopic node positivity. There are certain features like T3, T4, Gleason 8 or more, and PSA 30 or more, which are included in nomograms, and you predict the probability of node positivity. So the third group is important because all of the studies which treated node positive patients have included the third group in large amounts. The actual imaging wise node positive patients will be around 30 to 40%. The rest 60 will be constituted by the third group. So regarding the second group, imaging is the important modality which defines your node positivity. So the mode of imaging matters. This is a systematic review which was published in World Journal of Men's Health, which compared the sensitivity and specificity of MRI and molecular imaging like PSMA PET. You can see that on the graph A, the sensitivity of PET is around 65% for detecting node positivity. While on the graph B, the sensitivity of MRI is around 41%. So this is a study comprising of around 1,597 patients. So you can see that there is around 20% absolute difference between the sensitivity of MRI and PSMA PET. So if you are doing an MRI and saying that this patient is not negative on MRI, you can 1/5 of those patients can be not positive. Now, this is a prospective study, another study comparing, this was done in Australia, comparing the CT versus PSMA PET in detecting node positivity and metastatic disease in CA prostate. You can see that the sensitivity of CT was around 38%, while that of PSMA PET was around 91%. So you are actually missing 1/3 of the patients who are not positive with PSMA PET by doing a CT scan only. And in case of metastatic disease, the sensitivity difference is between 95 and 74%. So there is a 22% absolute difference. So around 1/5 of patients who are staged as N plus in your CT scan may be harboring metastatic disease. Why this is important is that most of the studies, all of the studies which I am going to talk have been done with CT only. So the mode of imaging in all these studies were CT scan. So even in the European Association of Urologists, you can see that the T3, T4, N plus disease based on CT or bone scan is considered together as locally advanced high risk disease. So your T3, T4 disease on a CT may be an N plus disease in 1/3 of patients, and an N plus disease on your CT may be a metastatic disease in around 1/5 of your patients. So, but the guidelines as of now have suggested CT only. Now, if you look into the NCCN guidelines, you can see that pelvic node positive disease is stage grouped as 4A, making them potentially incurable. So that is also based on CT. So all this, whatever I have told, as was said, just to say that N plus disease in CA prostate is a gray zone. Actually, N plus on CT may be a metastatic disease, and your T3, T4 Gleason high, PSA high patient may be an N plus disease on your molecular imaging. Historically, node positive patients in CA prostate were treated with ADT alone. So first the integration occurred with radiation into the treatment of node positive CA prostate. Initially, ADT alone was given. Then, when the Stampede report came in favor of local treatment for metastatic disease, they, they became enthusiastic about the node positive disease, and people started analyzing N plus disease alone. These all patients are CT N plus disease, and these are very few patients because primarily N plus prostate cancer forms around only 10 to 15% of newly diagnosed prostate cancer. So these are a relatively small group. So there are no prospective data comparing addition of RT along with ADT in N plus disease. So we rely on retrospective evidence, whether to add RT along with androgen deprivation therapy in N plus disease. And this retrospective analysis from Christie has shown that there is a huge difference between patients who had RT and without RT in node positive patients. That is in terms of overall survival, progression-free survival, and also in biochemical failure-free survival. So they concluded that addition of prostate radiotherapy to ADT in N1 M0 prostate cancer yielded improved disease control and overall survival independent of other tumor and treatment factors. This study included around 390 patients, and this is retrospective also. There is another larger systematic review and meta-analysis based on retrospective data, including 8,522 patients across 8 studies, N plus TX, N plus M0 patients. And they concluded that local therapy in the form of either radiation or surgery had better overall survival. So the incorporation of RT along with ADT is definitely better. So, and whether additional benefit will be obtained by adding on systemic therapy along with RT, along with ADT, was looked into in the Stampede platform. This was phase 3 trial of meta-analysis of 2 phase 3 trials of the same Stampede platform. The patient characteristics were same, and the 2 studies, one study compared ADT plus RT. The other study, ADT plus RT versus ADT plus abiraterone plus RT. The second study compared ADT plus RT versus ADT plus abiraterone plus enzalutamide. So you can see that there was around 1,900 patients altogether, both the studies combined. And you can see that N plus patients constituted around 40% of all these patient groups. And it is also interesting that around 15 to 20% of patients did not receive local RT in the study. So they were treated either with ADT plus abiraterone. Most of the patients who did not receive RT were in the ADT plus androgen receptor pathway inhibitor arm. So this is the result, 6-year metastasis-free survival, which improved from 69% in the control groups, that is ADT plus RT alone, versus 82% in the combination therapy, that is by adding abiraterone or abiraterone plus enzalutamide. You are gaining around 13% improvement in metastasis-free survival. Metastasis-free survival in node-positive disease is a forerunner of overall survival. So it is a positive study, and the overall survival improved from 77% in the control group to 86% in the combination therapy group. So both the arms, both the studies, the study in which abiraterone alone was added and the other study in which abiraterone plus enzalutamide was added, had similar results. And the authors concluded that men with high risk, I said that the patient who are not positive in this study were forming around 40%. So it was majority of high risk locally advanced disease. So men with high risk non-metastatic prostate cancer who receive ADT with combination therapy have significantly better metastasis-free survival and overall survival than those who receive ADT alone. So they suggested that 2 years of abiraterone and prednisolone added to ADT, and if indicated radiotherapy, should be considered as new standard of treatment for non-metastatic prostate cancer with high-risk features. So this is the landmark trial which brought in abiraterone into the systemic therapy of N+ prostate cancer. So if you are treating an N+ prostate cancer based on a CT scan, you are entitled to add ADT plus abiraterone for 2 years. Now they tried with docetaxel also, addition of docetaxel along with RT in N+ disease. ADT, docetaxel and RT. Docetaxel was, this arm was a little hectic because a patient who started on ADT and 6 cycles of docetaxel and then taken up for radiation. So radiation was not that mandatory in this study. You can see that 40% of patients were N+ disease and around 40% did not receive RT. So they were managed with ADT plus docetaxel alone. Most of the patients who didn't receive RT were N+ disease. So the metastasis progression-free survival was not significant in this study with a p-value of 0.4, but biochemical failure-free survival was significant, and overall survival was also not significant. And the authors suggested that the patient number was also low. The other study, abiraterone study, had around 2,000 patients. This study had around 350 patients. So the significance was not obtained, maybe because of the low patient number. Or it can be due to the omission of RT, we don't know. There are similar studies of addition of docetaxel into N+ disease along with RT. The analysis of all these studies show that for patients planned for radical radiotherapy with N+ disease, upfront chemotherapy can be avoided. We know that anything abiraterone can do, enzalutamide also can do. So this was from this was the abstract in ESMO last year. So they added instead of abiraterone, enzalutamide along with ADT and RT for node positive and locally advanced disease. The addition of enza to ADT and RT had limited effects on metastasis-free survival during 8 years. And this study also had only 800 patients, around 800 patients. And the metastasis-free survival was not significant, but it was, when they did the analysis, they found that the effect of metastasis-free survival were larger on patients with positive pelvic nodes on conventional imaging and those with pelvic RT plant. So overall population, it was not significant. And anything abiraterone and enzalutamide can do, apalutamide will also maybe do. So they are trying with the Atlas trial and darolutamide in the Thunder trial, though the results are not out. So if you looked into the guidelines, they say that given the metastasis-free survival and overall survival benefits observed in the overall population, addition of abiraterone for 2 years along with ADT and RT should be standard of care in N+ prostate patient. And in NCCN guideline also, N+ is put as regional prostate cancer, and the preferred treatment is, if your life expectancy is good, the preferred treatment is RT plus ADT plus abiraterone for 2 years. Thank you.
Thank you, John, for the nice exposition of the subject. In all the studies, they were they depended on CT scan, usual normal CT scan. In our clinical practice, are you still deciding your systemic therapy or the pelvic node status on CT, or you depend on other imaging modalities like MRI or PSMA PET?
We do the local staging with MRI, and the rest of the staging is with CT only, routinely.
Depend on PSMA PET CT?
We do for some patients, but as it is a government hospital, it is not reimbursed, and because of the financial constraints, we are not doing for every patient.
Any questions from the audience?
So you were telling about abiraterone for 2 years.
Yes.
Say the patient is stable after 2 years, would you like to continue or stop and follow or watch?
The authors in this study have stated that 2 years is an arbitrary time period, and they have suggested that maybe even lesser duration of abiraterone may be effective. So that has to be proven with another randomized study. There is no data to continue as of now.
So after 2 years you can stop?
Yeah.
Your clinical practice, what is the schedule you are following? How is the tolerability to the schedule with the muscle package with radiation and all that? In actual practice, what percentage patients?
Yeah, node positive, N+ node positive patients are smaller in number, rarer in number. We start with ADT and abiraterone if they are N+, and so also for Gleason 8, T3, T4, and PSA more than 30, we start on ADT plus abiraterone. And if they are not positive, and also for locally advanced, they start RT after 3 months and continue ADT after RT also. the RT will be around, if they are not positive, we give 68 gray. You can go either way. You can go either the conventional fractionation or the hypofractionated.
Thank you, John. If there are no more questions, we'll wind up this session. Thank you.
Thank you, sir, for that clinically insightful presentation. We continue with the urological malignancy session. It's my privilege to invite Dr. Kausar Talapatra, Senior Consultant, Nanavati Max Hospital, Mumbai, to deliver the lecture on oligometastatic prostate cancer, radiotherapy to all sites or only to prostate.
At the outset, I would like to thank all the organizers for this opportunity, to all the members of the Kerala Aroicon chapter. My topic is oligometastatic prostate cancer, and this debate has been going on for some time, radiation to all sites versus radiation to prostate only, and I will do an evidence-based review. So what are the learning objectives? Understand the rationale of treating the primary tumor, understand the rationale of treating all metastatic sites, review key randomized and the prospective trials, compare prostate only, metastatic directed therapy, that is MDT, and the combination strategies, and in the end I am going to summarize all the guidelines. So first of all, what is oligometastasis? There is a lot of talk going about. Some studies have called it 5 lesions, some have said 3 lesions, some have said 5 total lesions, but not more than 3 sites. So to clarify is, there is a ASTRO consensus document, and they say oligometastasis can to date be defined as 1 to 5 metastatic lesions, a controlled primary tumor being optional, and where all metastatic sites must be safely treatable. So that is the ASTRO consensus paper. What is oligometastasis prostate cancer? I think it is less than 5 lesions, 5 or less lesions, and it's being increasingly detected with PSMA PET-CT. So most of the international studies which are occurring currently, you should be seeing that the use of PSMA PET-CT in detecting oligometastatic disease is increasingly becoming more prevalent and more prevalent. Treatment strategies are radiotherapy to prostate only, MDT to all visible sites, systemic therapy alone, or combination of all these. So let us see the studies now. So my part 1 of my talk is radiation to prostate only. So there have been 2 major trials. I'll not explain in detail, rather I'll throw the concepts. There have been 2 major trials, rather 3 major trials. So, but the 2 ones, 2004, the HORETS trial started, and then the H arm of Stampede trial, the original Stampede trial. So let us see what HORET and Stampede have talked about. So this is the HORET study. It was a multicentric prospective open level 2004 to 2014. Primary endpoint was OS, secondary endpoint was PSA progression. 432, not a small number, 432 patients were enrolled. The control arm received ADT alone, and the experimental arm received ADT plus EBRT to prostate only, which is 70 gray in 35 fraction, standard fractionation. What were the results? There was no significant difference in the median overall survival by adding radiation to primary, but there was a trend towards PSA progression benefit when you added radiation to the primary. Then we come to the most evidence generating, one of the landmark studies. Of course, this was a study for different purposes, but it was a randomized controlled phase 3 trial, and the H arm was radiation related, so we will stick to that. It was stratified by low metastatic burden and high metastatic burden by the old charted trial. So what is low metastatic burden in charted? So first to define the high metastatic burden. More than or equal to 4 bone metastasis with one outside the vertebral body or pelvis, or you have any visceral metastasis. So that is high burden. And what is low burden? Anything that is not high is low burden. So that is how they classified low burden and high burden. Here, unlike Hoddett's trial, they use moderate hypofractionation or extreme hypofractionation in the Stampede H arm. That is 55 gray in 20 fractions or 36 gray in 6 fractions. So the SOC, that's the standard of care, was ADT plus minus docetaxel and chemohormone combination, and the other arm was SOC plus radiation arm. And the results was in the low metastatic burden arm, it showed a overall survival benefit, but no overall survival benefit was seen, and that is when radiation to prostate only in oligometastatic setting with a low metastatic burden got established. So this is a very important trial. So this is a systemic review of AIRO, the Italian oncology, and they included all the key trials, and their key conclusions was RT to prostate improves overall survival in low volume metastatic disease. However, in high volume disease, there is no proven OS benefit. They also talked about the symptoms, that is, radiotherapy reduces local symptomatic complications. So we have talked about what is low volume, what is high volume, and radiation is most beneficial when it's given in the low volume setting. And so based on all this, this is the summary slide. So radiation to prostate only has become the standard of care as per the AU and NCCN guideline in low volume disease. Now let us see radiation to metastatic. So it's very clear, radiation to prostate only. Now let's see radiation to metastatic sites, that is metastatic directed therapy. What are the evidence bodies we have? This is the concept, why we treat, we all know. These are the reasons, and these are the proposed reasons why you should do metastatic directed therapy. So the first trial, there was the STOMP trial. Small study, I think some 62 odd patients. It was MDT and surveillance. So there were two studies, STOMP and Oriole. They had MDT after primary treatment. This was for oligoprogressive or oligorecurrence disease, and they had two arms, that is MDT, that is metastatic directed therapy, and surveillance only. They did not initiate, we have to remember that they did not initiate, neither STOMP nor Oriole initiated hormone therapy then and there. What was the STOMP? 5-year ADT free. So STOMP looked at ADT free survival, and next slide I'll come to Oriole, where they looked at 6 months progression free survival. This is showing a trend. 5-year ADT free survival is better if you do metastatic directed therapy at oligoprogression as compared to observation alone. Similarly, I was talking about Oriole. It clearly showed that a 6 months progression-free survival was better if you do treat with radiation as compared to observation alone. But again, both were phase 2 trials because the number of patients were 62 and 54. Local therapy, one thing we must remember, the differentiating factor between STOMP study and Oriole study is that STOMP study had radiation oblique surgery as the local therapy, whereas Oriole study had only SBRT as its local therapy. This is another important trial. It was EXTEND trial. What were the arms in EXTEND trial? Though it was a phase 2 randomized controlled trial, they have utilized ADT as compared to observation in the previous 2 studies. EXTEND trial has utilized ADT. So the first arm was, the control arm was ADT alone, and experimental arm was metastatic directed therapy, either SBRT or surgery to all visible sites. They have used intermediate ADT and continuous ADT, and in both the cases, if you used a local therapy, your median PFS was better, whether you use intermittent androgen deprivation therapy or use continuous androgen deprivation therapy. If you add a local therapy to the metastatic sites, your progression-free survival is better. So this is a review of literature, again analyzed all this STOMP, Oriole, and all the published data, even Saber Comet they took. What was their conclusion? MDT, that is metastatic directed therapy, metastatic directed therapy prolongs ADT-free survival, and outcomes was 2 years overall survival was to the tune of 97, and PFS was to the tune of 46%. These are the graphs. I will not get into the details of this study because of constraint of time. Now let us, so we have talked about prostate-only radiation therapy. Stampede, original Stampede H arm has clearly established that in low volume metastatic disease, radiation to prostate should be added. We have talked about metastatic directed therapy only where your STOMP and Oriole trials have shown that, although they have not shown an overall survival benefit, but they have shown some data that if you do metastatic directed therapy at an oligoprogression or oligorecurrence, it is more advantageous in terms of PFS as compared to if you just observe with ADT plus just observation. Now the question is, should you add metastatic directed therapy plus prostate radiation? Till date, there are a lot of phase 2 trials, there are a lot of systemic review, but the study which is going to give us an answer to this is the Stampede 2 trial. Stampede 2 trial is currently underway. This is a survey of the Stampede 2 trial, and there is an arm in Stampede 2 trial which is evaluating radiation to the prostate plus radiation to all the metastatic sites. And the early signs from that is definitely showing that there could be an improvement in, we may get a positive result out of the study. So this is part 3, which I was talking about, prostate RT to MDT. These are the rationale for combination of prostate RT and MDT. This is the extent phase 2 trial. After this, people started thinking that we should, because there was so much improvement with MDT, even after using ADT, that is androgen deprivation therapy, people thought, why not combine the prostate radiation plus metastatic directed therapy? These are some systemic reviews which have shown that in de novo low volume metastatic hormone sensitive prostate cancer, combination of radiation to prostate and metastatic site is superior to prostate only radiation, and the 2-year biochemical progression-free survival is to the tune of 82%. This is another review, comprehensive review, and this has also shown that a combination, while standard of care is currently prostate radiation plus systemic therapy, but a combination may play a role. So now, my last part of it, I will now summarize what I have talked about, and in your clinical practice, what is the evidence and what are the proposals that one should do. So for low volume de novo metastatic disease, till date, that is where the evidence is very robust, arm H of a well-designed 2,000 patient randomized controlled trial, improved overall survival by prostate only radiation. So low volume de novo metastatic disease, prostate only radiation. For an oligo recurrent disease, there is evidence of metastatic directed therapy, and it has come from 2 or 3 trials, more and more. So in the 2025 in APCCC consortium, lot of people voted for metastatic directed therapy, and I'll also come to metastatic directed therapy and the radiation. So consider metastatic directed therapy in oligo recurrent disease. What about oligo progressive disease? So that is where you have a prostate primary, you had oligometastasis, and now you have two more sites of, or two more oligocytes. So that's an oligoprogressive disease. So in an oligoprogressive disease, there is data, as I talked about the H arm of STAMPEDE and few other phase 2 trials. There is emerging data which is talking about prostate radiation plus metastatic directed therapy, but actually currently there is no robust evidence to that. Maybe in 1 year's time we will have some evidence. So this is what NCCN says. This is exactly what, for a low volume disease, this is exactly what we talked about. And they also say for synchronous oligometastasis or metachronous oligorecurrent, which we talked about, MDT may be considered, and that is what we have been, metastatic directed therapy. We have, that's what we have been talking about. This is the APCCC takeaway from Japan 2021-25 consensus. Primary prostate radiation definitely supported, especially staged with PSMA PET. So as I said, usage of PSMA PET is widely coming in. Metastasis, MDT, while there is no strong universal consensus, almost 50% of the consortium group voted in favor of metastatic directed therapy. So that's why they have put a conditional remark that it may be used. Role of systemic therapy first versus which one should you use? If you have oligometastasis, should you use systemic therapy first or MDT first? Many experts favor systemic therapy first in most metastatic setting, and MDT can be considered for oligo progression. And we have been talking about this imaging impact on RT decision. One slide about radiation dose fractionation. Prostate only radiation, STAMPEDE 55 in 20 and 36 in 6. MDT, there are various. For bone, people have used 20 in 1 or 30 in 3, and lymph node 30 to 35 in 5 fractions. Toxicity consideration, we all know, but it's important to talk about toxicities. So this is my final slide and take home messages. Oligometastatic prostate CA has a distinct therapeutic window. Prostate radiotherapy improves survival in low volume de novo metastatic disease. MDT delays progression, and ADT use in oligorecurrent setting. Treating all sites is promising, but still under investigation for overall survival, and management of patients must be individualized. Thank you.
Thank you for the excellent talk on this very controversial subject, oligo. Any questions from the audience? No questions can be allowed.
Regarding the continuation of androgen deprivation therapy, yes, so usually recommended for 2 years.
Yes.
So in metastatic setting, is there any different recommendation?
So see, most of the studies have used for 2 years only.
2 years only. So the patient.
And then, but metastatic, once your oligo progress, then you have to change the
to systemic chemo.
Either you systemic chemotherapy or you have to add abiraterone. So that the metastatic setting is a very fluid thing. Unlike your locally advanced node positive, which is more of a static thing, metastatic setting is a very fluid thing. Today you may have 4 metastases, you are using one agent, and after 3 months you will see 5 more metastatic sites. So you have to change your strategies. So I mean, usually they have used 2 years, but there is no standard guideline as such. You have to optimize based on whether there is a progression or not.
So as long as patient tolerates without toxicity.
It's 2 years.
As long as patient tolerates without any toxicity, is it the dictum? Continuation of treatment, continuation of adjuvant treatment.
I think no study talks about that. No study talks about that.
Thanks, Kaustubh. That was quite lucid take on things. I just want to know, when you do MDT, do you do it upfront before ADT initiation, or do you do it after a few months of ADT? And if you're doing it later, if the PSMA shows the mets have disappeared, do you still radiate those sites?
So you know the MDT concept is evolving now, because most of these patients, oligometastatic patient, in my practice at least, they come from medical oncologists. Medical oncologists straight away start off ADT. But if you ask me ideal case situation, now we are in a better situation where we are doing MDTs at least for 30 to 35% of 1 out of 3 patients. And we have been pushing our medical oncologists, but the right time to do is upfront, when the patient is index case, when the case is indexed and you have not started any treatment.
Bisphosphonates for
I think someone who is doing, sir, maybe Dr. Francis may be the right person to talk about.
There is no place for bisphosphonate in hormone-sensitive metastatic disease. It's only for CRPC. It is out of question in this situation. Second, regarding the duration of hormone therapy, for all metastatic prostate cancer, the antidepressant therapy is permanent. There is no duration of 2 years. That's only for locally advanced disease. So even for oligometastatic disease, there is no 2-year hormone therapy. There's no confusion. Those are fundamental things, so PGs shouldn't get confused. So that's why I'm clarifying. For all metastatic disease, it is permanent androgen deprivation, not 2 years. The 2-year business come for localized disease, which are high risk for recurrence.
But you will have to add ARPI and all those things as and when the situation starts, right?
That's when they become CRPC or very high risk, localized, like patients with positive lymph nodes or PSA running to hundreds and stuff like that. That's a very small subset. Thank you.
In our clinical practice, we always continue the systemic treatment, even if we are given prostate RT or MDT. That is, we don't stop.
Therapy, but there's a lot of data coming on when to start ARPI and those kind of things. Triple therapy, ARPI. So what systemic therapy comes into play after that? What systemic therapy?
For if the positive constraints of time, we'll stop the discussion here and we'll pass on to the next session. Thank you for the excellent.
With utmost respect, it's my honor to invite Dr. Kaustubh Talapatra to kindly come forward to receive a token of our appreciation. May I request the session chairs, Dr. Sivaramakrishnan sir and Dr. Shashidharan sir, to present the memento. May I now kindly invite Dr. John Joseph to receive the memento from the session chairs. We would also like to acknowledge our respected session chairs. May I now request Dr. K.L. Jaikumar sir to kindly hand over the mementos to our session chairs, Dr. Sivaramakrishnan sir and Dr. Shashidharan sir. Next, we have a panel discussion on salvage radiotherapy in prostate cancer, who, when and how. For moderating this session, I invite Dr. Anto Baby, Senior Consultant, Radiation Oncology, Parumala Hospital, Pathanamthitta. I also request our esteemed panelist, Dr. Jose Paul, Consultant Radiation Oncology, Rajagiri Hospital, Dr. Siniraj R., Associate Professor, Radiation Oncology, MCH Trivandrum, Dr. Satish Patmanabhan, Senior Consultant, Radiation Oncology, Aston MIMS Calicut, and Dr. Abarna MP, Associate Professor, Radiation Oncology, Amrita Hospital, Kochi, to kindly join him on the dais. My apologies. I invite Dr. Abarna, Associate Professor, Radiation Oncology, RCC Trivandrum.
Good afternoon, everyone. First of all, thank you, Aroicon Kerala chapter and scientific committee for giving me this opportunity. I have the misfortune of presenting the last session of today's conference, so I will rush through the slides and we will finish in 20 minutes. For going to the salvage radiotherapy and the strategies, let's start with what is meant by salvage radiotherapy. So basically, salvage radiotherapy is a radiation treatment given to the prostate bed mostly after radical prostatectomy when there is evidence of biochemical recurrence, which is usually detected by a rising PSA level in patients without a visible distant metastasis. So it's a secondary treatment after surgery done with a curative intent when there is evidence of recurrence. Why it's relevant? Because salvage radiotherapy is the only proven curative option in patients who recur after undergoing the radical prostatectomy, and there is a 70% of patients who undergo salvage radiotherapy are disease-free at 5 years. So it's a very important curative treatment. Now, keeping up with the tradition of ladies first principle, let's start with Dr. Abarna. Dr. Abarna, what do you mean by biochemical recurrence after radical prostatectomy, and what is the incidence of biochemical recurrence after radical prostatectomy that you are seeing?
Okay, after radical prostatectomy, ideally PSA should be undetectable. So if any rise in PSA more than 0.1, earlier the concept was like 0.2. There is EAU guidelines, NCCN guidelines, many guidelines, but we have to make sure it is a biochemical recurrence by multiple measures. So we take a threshold of more than 0.1 nanogram per ml in 2 consecutive measures. And going to the second question, that incidence is about 20 to 40%, but it varies. When we are dealing with the low or intermediate risk, it is very low. But some urologists who are very aggressive, they do on high-risk patients that often land up in margin positivity, semivesical positivity. In that case, the risk of biochemical relapse is to the tune of more than 40%.
Yeah, in general, it's around 30 to 40%, but as Dr. Aparna said, it varies by the risk category. And next question is to Sindiraj sir. Why is the pre-salvage RT PSA is important? Whether it is important for prognosis, whether it is important in case of treatment, why the pre-salvage RT PSA is important?
The pre-salvage PSA should be ideally less than 0.2, because the success, you can see that actually the success rate PSA at the start of salvage radiation therapy, if it is less than 0.2, the success rate is more than 70 to 80%, and it slowly comes down with increasing PSA, and more. If it is more than 1, actually the success rate is less than 40%. And here you can actually see the greater impact on the relapse-free survival. It drops to 2.6% for every 0.1 nanogram per ml PSA increment. And also the progression-free survival rapidly drops to 18.1% for every 1 nanogram increase in PSA.
Okay, excellent. Now my question to Sadish sir. How do you select patients for salvage RT? Do you treat every patient who presents to you with biochemical recurrence after radical prostatectomy, or is there a selection criteria for patients? What's your take?
See, ideally high-risk patients defined as seminal vesicle invasion, Gleason score more than 8, and a significant PSA more than 0.5. Definitely they are candidates, and a good life expectancy.
Yeah.
And the main thing is they should be distant metastasis free on imaging, and once we clarify that, we discuss and proceed with salvage RT.
Dr. Jose Paul sir, let's assume a patient walks into your clinic. He had undergone radical prostatectomy 1 year ago. Now he comes with a single PSA value of 0.3. What will be your next step? Will you check PSA after some time, or will you go for straight imaging? If you are going for imaging, which one will you choose? What's your how you are going to proceed?
Yeah, most likely they would have done a post-op PSA.
Okay.
And if the post-op PSA was very low, and it's very unlikely that you haven't had any PSA for 1 year. So most likely
just imagine he lost all the records.
Okay, if there are no records, and if it's 0.3, then I would reconfirm the 0.3 because I don't want to treat based on a lab error, and I'll definitely ask for a PSMA PET scan. Make sure that there's no metastatic disease. 0.3, I don't think I would wait any further.
Okay.
I'd just reconfirm it and I'll probably treat it.
Okay. You will prefer PSMA PET CT always over MRI and CT?
Generally,
is it mandatory? Is it mandatory?
Generally, PSMA PET CT.
Okay.
If the patient has logistics, a prostate blood MR would be ideal because you might occasionally pick a residue which you would be able to boost, but not always.
Okay. One hypothetical question. In any case of post-radical prostatectomy recurrence, do you prefer FDG PET CT to PSMA PET CT?
Generally PSMA.
Okay.
Generally PSMA.
See, this shows the high sensitivity of PSA, like Sir said, high sensitivity of PSMA PET to very low PSA levels. Even below 0.5 threshold, it's almost 60% sensitive, and as the value climbs up, the sensitivity goes on. And PSMA PET is very important in precise localization of the recurrence, and it's very helpful in planning, and it's also because of the information that we get from the PSMA PET CT, we can reduce the treatment volume and thereby reducing the treatment toxicity. And there is evidence also, there's a PSMA SRT trial which showed that when you do a PSMA after biochemical recurrence, in 1/3 of the patient, there is treatment decision changes. So PSMA PET, whenever available, it's mandatory or it's a good thing to have. It's a simple algorithm. You take a PSMA scan. If it is a negative scan, you don't keep the patient on follow-up. You treat the prostate bed only. If there are positive nodes or any positive sites, then you treat the prostate bed with the concerned area. If there is visible distant metastasis, it's better to go with the systemic therapy. Dr. Aparna, what is the optimal timing for initiation of salvage radiotherapy? What is your take on adjuvant radiotherapy versus early salvage radiotherapy, and what's the evidence in this regard?
So there was a retrospective analysis by Dira Telki. So the concept was earlier it was we used to wait till PSA reaches 0.2, but that later in their study they told that when you wait, each 0.1 rise in PSA will reduce the biochemical control by 2.6%. So nowadays we are moving for a consecutive rise in PSA more than that threshold, and the 3 trials, the Radicals RT, ROSE and JET2, showed that salvage RT is better, and it was proved in the arthritis meta-analysis also.
Yeah, sir,
and
there is
one more thing.
Continue. Yeah, that was a question. Why you prefer early salvage rather than adjuvant?
When we are considering salvage RT, the arthritis meta-analysis concluded that only 33% of the patients only needed RT. Rest of the patients RT could be avoided, and there was no detriment. So one thing, when you consider all these trials were done in the era 2006 to 15, and PSMA PET was not much standard at that time, and most of these patients included are in the average low risk. They stratified into one Capra score. Most of the patients were intermediate risk. So their baseline PSA before surgery was 10. So in our situation in Kerala, it's not the situation. So you have to see that any consecutive rise, or most of the times there will be persistent PSA as well. So you know it's not dictum. Salvage RT is not the dictum. In low risk biochemical relapse, salvage RT we can consider. But in patients with persistent PSA or baseline high risk features, sometimes you need to consider adjuvant RT.
Sir,
and also till maybe 5 years before, the mere margin positivity, as clinicians we were restless comparing to other sites. So there were one group which tended to go ahead with adjuvant RT, But now the data is very clear. Salvage RT is good, not just good enough, it's safer also.
Yeah. Toxicity is definitely less. The problem is many times urologists after surgery seeing the pathology report, they send patient to us and they counsel the patient also, you need adjuvant RT. Then it's a task for us to convince them that salvage RT is equally good and more toxicity is less.
It's a bit easier than the other way around.
Yeah. My question to Siniraj sir, we know that with the salvage RT, even with the salvage RT, 30% of the patient will relapse in 10 years time. So there are ways to mitigate that recurrence risk. One of them is to add ADT. We know, like Francis sir said, in radical cases, we give ADT for 2 years in high-risk cases. So what's the role of ADT in a salvage setting? Is there any evidence how long you give? If you are giving ADT, for how long you will give? Which agent you will use? Please give your opinion.
Actually, you have to find out not all patients require an androgen deprivation therapy. Mainly, this the low risk features. There are no low risk patients. If there are no high risk features, only radiation therapy is required. High risk features are the high PSA values, 0.7, higher Gleason score, then seminal vesicle invasion, all those things. Short term androgen deprivation therapy is mainly useful for intermediate risk patients and patients with a higher PSA value and very high risk features may require a long-term androgen deprivation therapy. That is proven in the RTOG trials.
But still, I think there is no consensus regarding the optimum duration of ADT in salvage setting. We go by risk criteria and all, but I don't think there is any clear consensus like the case of radical, like what we do in radical radiotherapy for intact prostate.
All these trials, they have used ADT. In the RTOG 9601, they used 2 years of bicalutamide. In the radicals RT, 30% of the patients received ADT. And again, you have to think the biology of the disease. You have to consider when the patient relapses, see the time interval between the relapse, the Gleason score, and the PSA doubling time. If a PSA doubling time is less than 9 months, you are playing with a aggressive disease. So you have to incorporate that ADT. And in the recent EMBARK trial, the 25% of the patients were with the prostatectomy. So they considered in a PSA doubling time less than 9 months, they intensified with the ADT and enzalutamide.
My question to Jospol sir, is there a role for pelvic lymph node radiation? I mean by prophylactic pelvic lymph node involvement in the field in case of salvage RT.
Okay. Pelvic lymph node radiation in prostate cancer is just a never-ending debate with two philosophies. 50% of us will irradiate, 50% of us won't. In general, yes, I would irradiate, but yes, you can argue the other way around also. Yeah. Post-op, I will generally almost always irradiate.
Okay.
So, it's a difference of opinion. I may not be
That's what Sir also said. Yeah, there's two sides to that argument, and you are not going to win that argument.
Sir, one point is in the PSMA PET era, when you map the nodes, so many of the nodes are outside your standard conventional cornering guidelines.
And no, if you do
that's true. That's true. But that's probably not an argument for avoiding pelvic RT. It's just that we will still see unusual failures. Okay. But most of the failures would, I mean, if at all they fail in the nodes,
Sadish sir wants to add a point.
Yeah, the high risk features as we see, if upfront there was nodes or a PSA doubling, which is we are dealing with a probable aggressive disease, high Gleason score, those and significant more than 0.5 biochemical recurrence value, definitely we should strongly consider pelvic nodal radiation. The other thing is always a debate never ending, as Dr. Jose.
If the urologist has done a lymphadenectomy previously, do you radiate?
I would still irradiate because, sir, there are two things. One, a urological lymphadenectomy is never as comprehensive as never as comprehensive as a pelvic lymph node dissection for a gynec malignancy or things like that. So that's one thing. Secondly, yes, as a matter of philosophy. And thirdly, most of the things that we see, at least in the private sector, are not low or intermediate risk prostate cancers then coming up for early salvage. They are almost always high risk prostate cancers coming up for, salvage radiotherapy. I don't think I would avoid pelvic nodal radiation in that subgroup.
Low risk I always avoid if they have done it. Otherwise,
Another thing is there is, as the previous speakers highlighted, there is at least a good subset where it remains loco-regional for a long time. So that again supports the philosophy of irradiating.
We have data also adding pelvic lymph nodal artery to a prostate bed will decrease the freedom from progression, and like Jospol sir said, in a high risk case, even though the PSMA PET is negative, my personal practice, I include the notes also. Okay, I differ with the Dr. Aparna, but that's my practice. Now coming to how the radiotherapy is performed, what technique of radiotherapy use, dose. I will start with Jospol sir. What is your usual practice? Which technique do you use? Which dose you give?
Mine is 66 gray at a minimum, and generally going up to 70 gray. Yes, there are the occasional toxicities, I accept that. But generally going up to 70 gray, I mean, not exactly in the context of, I mean, I'll tell you, where I limit to 66 gray is not salvage, generally for a node positive adjuvant, if I am giving, I will not go beyond 66 because the risk of systemic failure is generally quite high. But if I am looking at a sort of patient who is likely to fail locally, I'll probably go up to 70 gray. But the last 4 gray would be a very, very mini pelvic field.
Francis sir wants to add a point.
There was a randomized trial which showed no benefit of increasing dose.
Beyond 64.
64 to 66 is adequate, no more benefit, except for probably a patient who had recurrence.
Prostate bed recurrence.
Recurrence, which is gross.
So identifiable recurrence only you would go to 70.
So the basic concept is that the gross disease will boost. If you are treating microscopic disease, 64 to 66 is enough.
Okay.
If there is a pelvic recurrence, what will you do? What's the dose?
So that's what. If it
that's a dose is the bedil there is a recurrence.
Yes,
what will be your dose?
Suppose if it is PSMA PET negative, in either way we treat yes sir. So in that case 64, 66 should be sufficient.
Enough.
When we have a measurable disease, clinically or radiologically, definitely 70 gray and 35 fractions, sir. Sure. I personally don't have.
We're coming to that, sir. We're coming to that. What is the role of hypofractionation? Anyone? Anybody using hypofractionation for salvage RT?
There is a role for hypofractionated RT, especially the hypo-RT trial, which showed us that 62.5 in 25 fractionation is as effective as a conventional radiation treatment regime. Only problem is that actually there is a slight increase in the acute GI toxicity, but it is a transient thing. It will settle after 1 or 2 years.
And also the radicals RT trial also 30%, but the dose was less, 52.5 in 20 fractions. Anybody using that dose? Any of this dose? I haven't used. Anybody has experience? Which dose are you using, sir? 62.5 in. Okay. Nice. Now, coming to the contouring for radiotherapy, I will just skip through this because I think everybody knows. Just for the PG's sake, Dr. Aparna, how do you contour the prostate bed? Just give the boundaries only.
Actually,
you have to finish it in 5 minutes.
I follow, not this one, I follow extra-crop guidelines. So you have to find out you scroll through, you can see identify the bladder, that density is different, this density of bladder is different. So till the last most cut that is the uretrovesical anastomosis. From that, I'll give 2 centimeter inferiorly, but better to avoid penile bulb. And superiormost, I'll be using from the level, if depends on the seminal-vesical involvement. If seminal-vesical is involvement, you have to go a little bit up and involve the clips if possible. Anteriorly, you have to take the retropubic fat completely. Posteriorly, anterior rectal wall, and till that mesorectal towards the lateral end, you have to a little bit tilt towards the mesorectal.
Sorry for this picture, I pasted the wrong picture. Sorry for that.
Laterally up to obturator internals.
Now coming to the most important and the last part, the quality of life. We know oncology control or cancer survival should be balanced with the toxicity also. My question to Sadish sir, common side effects you observe during RT, acute side effects, what are the acute side effects usually you observe?
Acute side effects, mostly they are related to, again, depends on the field. Suppose if we are treating only prostate bed, most commonly cystitis, which is transient, nocturia, increased frequency, and dysuria sometimes. Hematuria we don't routinely see. If pelvic nodal irradiation is also there, then the lower GI side effects like diarrhea and cramps, they occur. And proctitis very rarely we see it during RT.
Okay. Sindhya sir, what are the late side effects that you observe after salvage RT?
Again, it is actually urinary and bowel toxicity. It's a urinary chronic issue. Is that chronic urinary urethral stricture, incontinence, hematuria, you can see. And bowel, again, actually it's a chronic proctitis. There can be incontinence and other things. Erectile dysfunction, one of the important thing.
Yeah.
That also is a chronic issue.
That also you have to counsel the patient.
Yes, yes.
Okay. Last slide, what are the future directions and emerging evidence? Like the Oncotop DX score in breast cancer, whether we can predict the benefit of chemotherapy in an early stage. We have genomic classifiers like Decipher coming up, and new PET tracers beyond PSM is being explored. Intensification of androgen receptor blockades are also studied in new trials. Just one word about Decipher, it's a 22 gene RNA expression signature. It will give you a score, risk score from 0 to 1. And if the score is more than 0.6, the data from the RTOG 9601 shows that if you add ADT in cases where the score is more than 0.6, it is going to, patient is going to benefit. Anything below 0.6, you better avoid ADT. So that's a future direction. Thank you all. Thank you all for listening.
Thank you. Thank you.
May I request all the panelists to jointly hand over the memento to the moderator of the session, Dr. Anto Baby, sir. May I kindly invite Dr. Prema KR now to hand over the mementos to the panelist. Ma'am, please. Thank you, ma'am and sirs. As we conclude the scientific discussions on prostate cancer, we now move on to an equally important dimension of oncology care, patient support and survivorship. I invite Mr. Ramakrishna G. Kumar to speak about the prostate cancer support group.
Good afternoon, everybody. First of all, thank you very much for AROI and particularly Dr. Francis sir for inviting us to talk and make a presentation here. After hearing all the detailed, very technical talks, I am frankly intimidated to talk to start with. I am not a medical professional. I am a prostate cancer survivor and founder, president of Prostate Cancer Society which we started about 2 years back. This initiative really started about 10 years back when I was diagnosed with prostate cancer while I was in Canada. I was treated with SBRT. I was originally treated with SBRT, that is 5 fractions of 8 grades, totaling about 40 grades. And after the treatment, in fact, I took the treatment under the randomized clinical trial. What is that? PACE B, that was about 10 years back. Now, our organization basically is a non-profit charitable organization registered, and it's a pan-India operations, and it is entirely founded and managed by prostate cancer patients. And the structure is that we have a managing committee which runs it, and we have a advisory board of doctors and doctors, oncologists, urologists, and Dr. Francis sir has helped us a lot in taking it forward. We have no paid employees, we are all volunteers, and the way we operate is we have peer group meetings once in a month if possible, depending on the number of patients, which gives a safe and secure place for the patients to discuss their anxieties and other problems. And we normally, once a patient approaches us, we try to connect him with a patient who has taken the same treatment earlier, so that he can explain to him what to expect while the treatment is being done. And this has been very successful in helping the patients, and we try to encourage patients to go through the literature, go through the videos of presentations made by medical professionals, and also we try to tell them what is the best diet possible, what exercises will help them, and also prepare them for the life after prostate cancer. And apart from this, when a patient newly diagnosed sees another patient who has been treated and is practically or normal, leading a normal life, it gives them hope that cancer doesn't mean the end of everything. The emotional aspect, according to me, is very important and helps the patient a long way to his progress. And we also provide one-to-one interaction with the persons if it's required. But normally all our meetings are online, on Zoom. We invite the patients to join the discussion and come out with their anxieties and other questions, which possibly they will not be in a position to ask the doctor, because what I found is most of the patients are very reluctant to ask the doctors very in detail, because particularly in the case of prostate cancer, what I found is many of the prostate cancer patients doesn't even want other people to know they have prostate cancer because of the other implications. In fact, I have 2 or 3 patients who told me that please don't tell anybody I have prostate cancer. And in a lighter mode, one person rang me up from his house in the evening around 9 o'clock saying that I am around 50, 55. I am engaged to to get married in the next 1 month. Somehow my future wife has known that I have prostate cancer. He wants to break up the engagement. Can you please talk to her that this is a temporary thing? I said, sir, that's not something which I can do, but this is the kind of problems the persons have, which is nothing to do with medical aspect. Similarly, one person told me that he has not told anybody about his condition because he is a small businessman. He has taken loan from the bank, and if the bank knows that he has prostate cancer, they may call back the loans. So these are practical problems which we come to know when we talk to these persons. So our aim is to enhance the life of a patient by interacting with them and talking to them from our practical experience, what to expect. When they, in my case, I was treated with SBRT only once, about 10 years back when I was 72 years. Now I am 82, and the last PSA reading about 3 months back was 0.048. And I had no other treatment. In fact, at that time, SBRT was not an approved treatment in Canada. So I had to take it to this randomized trial, and which again had because it was randomized, there was a chance I may not get the treatment, but still that was the option. And it has been quite a rewarding journey. And after that, when I came here, I was looking for a support group, which I couldn't find any effective one. So we had a meeting led by Dr. Francis sir. I took the opinions of a few urologists and oncologists, and all of them said that it's a good idea to start one. That is how we started the initiative. And we have about 10 or 12 patients now from all over India. We have patients from Punjab, patients from Hyderabad, patients from Chennai who contact us, and they want to know and get connected with another patient who is being treated by a similar or the same protocol. So to me it has been a very rewarding period, and we hope to take it forward with the help of all of you. And I sincerely feel that there is a requirement for a society like this, which is helpful to the patients and possibly, hopefully, take off some load from the doctors. This is the background of our society. Any questions on this are most welcome.
What percentage of patients will join the society if I tell them to join? What I found is if the recommendation is from a doctor or a hospital, it is more credible, so that more people, maybe about 70% of the people will join. But if we approach ourselves, the first question is how much I have to pay. But we don't, the whole service is free, all of us are volunteers. But the first question we get is, nowadays, if you say it is a society itself, there is a doubt, these people are out to make money. So that is the first hurdle we have to get over. But I find now this is, we are working with hospital like Rajagiri Hospital, we are working with our brochures are kept. In some hospitals our posters are kept, and these posters are kept in the urology OP clinic, so that when the patient comes, they are waiting for the doctor, they have time to read. They read all the whatever available to read. So from that they get the contact number and they have contacted us. So we are trying to push the visibility of our organization so that more patients can be benefited. That is the underlying thing we are doing. And we are extremely grateful that we got an opportunity to come and make a presentation. So thank you very much.
Thank you, sir, for sharing those meaningful insights. Your perspective reminds us that beyond protocols and evidence, patient support remains central to comprehensive cancer care. I kindly request Dr. Francis V. James, sir, to hand over the memento to Mr. Ramakrishna J. Kumar, sir. I kindly request all faculties and delegates to remain seated as we await the valedictory function.